So, to start the proceedings, now I would invite Dr. Seema Patni. She is the chairman of the scientific program, and she is a very, very senior member belonging to DMA North Zone. In fact, she was the first president, woman president of DMA North Zone in 2010 and 11. She professionally is a general surgeon with special interest in breast surgery, and she has been doing this right since 2008. And she is also involved in a lot of social work. She has done so many breast health awareness camps, and she is active in all the fields. In fact, she is the epitome of our lady leaderships here. So I invite Dr. Seema.
Thank you, Dr. Prashant Seth, for such a long and nice introduction of mine. I know most of the people know me out here. Good evening once again, and I'm very thankful to Dr. Dalmia and team to giving me this opportunity to organize this conference. Friends, today we have got the conference in two parts. First, there are two moieties. First is scientific session. Scientific session, we are talking about palliative medicine. Palliative medicine is basically it is little unknown in India, but in the Western world it is a well-established entity. Palliative care is an interdisciplinary medical caregiving approach aimed at optimizing quality of life and reducing suffering of people with serious complex and terminal illness. It is not very popular, but Dr. Sushma is doing very hard work on it. Today, we have the authority on the palliative medicine, Dr. Sushma Bhatnagar, with us. She is Department of Onco Anesthesia and Palliative Medicine, AIMS, HOD, and she is Chief of BRA Institute, Rotary Club, Rotary Cancer Hospital, and Head National Cancer Institute, Jajjar All India Medical Institute. She is the founder of Palliative Medicine Department in AIMS with DM Onco Anesthesia and MD Palliative Medicine, Palliative Care. She is well recognized person in her field and has received many prestigious awards with more than 300 national and international publications. She is founder of Pain Policy and End of Life Care Policy too, which is very new to us in India. Other than this, Sushma is very empathetic and humble person. With great passion, she works for her really terminally ill patients. Last but not the least, I know her for more than 4 decades. We are classmates, and it is my fortune that I am introducing her from this stage today. Thank you, Sushma. Thanks for coming and thanks for accepting the invitation. Please come over. Dr. Jyoti Chuk, please bring Dr. Sushma on the board.
Thank you, Seema. Thank you.
Dr. Jyoti, kindly hand over the bouquet to Sushma, a respect of honor.
इसको ठीक कर लें.
Center में आ जाओ.
ये कनेक्ट नहीं हो रहा. नहीं वो ये ना started with the when I saw one day a newsletter from DMA that Dr. Jagdeep Chugh is secretary of Delhi Medical Association, and I saw his newsletter. So I called him and I told him that everyone is doing so much in all over India, and I'm struggling with Delhi doctors to start palliative care in hospitals, to start or integrate palliative medicine in various hospitals in Delhi. So he immediately reacted and he introduced me to Dr. Ashwini Dalmia. Dr. Ashwini Dalmia is president of IMA, DMA. So he accepted my request that we will have a program on palliative medicine on 24th. And I was very happy that day that we will start. There is some beginning. So thank you, Dr. Dalmia, thank you, Jagdeep, thank you, Seema, and thank you, Dr. Jyoti, and good evening, everyone. Today, I have come, I will just introduce this subject in few slides, and then I have a big team from All India Institute of Medical Sciences. All senior people are here, head of emergency medicine, head of surgical oncology, pulmonary medicine professor, all my colleagues of professor of oncoanesthesia, professor from radiotherapy. All these people, we will have a good discussion and you are free to ask questions from them, and you will realize that how integration of palliative medicine in any of the hospital and any of the patient care will help your patient. So we will start with this, that we all are doctors. We all are doctors? Yes. So we all are doctors. When we were doing our MBBS and when we were doing our MD, everybody has taught us how to treat, how to diagnose a disease and then how to treat a disease. This much everybody has learnt? Yes? But when disease is not treatable, we all know that disease is not going to be treatable, but we still keep on treating that patient and keep on treating till the time patient takes its last breath. So we have not learnt something which is very, very important in medicine, and that's why I say that medicine is incomplete without integrating concept of palliative medicine. We have not learnt if a disease has become or disease has reached to a stage when there is no cure possible, how to handle, how to approach that patient. So we have seen a lot of advancement in medical science. We have started with our journey with 10,000 BC. We used to have witch doctors. चुड़ैल हुआ करती थी जो ट्रीट किया करती थी. Then came penicillin, then MRI, then polio vaccine. So many advancement has happened, and in these days we talk about robotics, we talk about immunotherapy, we talk about all the new molecules, nanotechnology, and so many things we talk. But we have not given any attention that all these medical advancements are definitely good for patient, definitely good for a certain extent in the sense, for example, it is good because initially cancer used to be incurable disease. Whenever a patient used to be diagnosed with cancer, he or she used to think that I am going to die, and cancer and death used to be synonymous. But because of the medical advancement, now it is no more. There are many cancers, those who are curable. There are many end-stage heart disease where patient lives a respectable life for a long time. There are many end-stage lung disease when treatment, because of the newer medical advancement, patient lives a respectable life to a certain extent. But all these patients ultimately reach to a stage when we know that treatment is not going to be helpful. Family members knows that treatment is not going to be helpful, but doctors, they don't know how to approach this stage of this patient. And that's why we are here to discuss, and I'm very happy that so many doctors are here and they are listening this. And definitely, even if you will treat a patient, one patient in a month, using basics of palliative medicine in your practice, I think we have succeeded by taking this lecture and panel discussion. So we will start with this simple, that progress of therapeutics, there are a lot of advancement has happened, but this is very, very important, and we need to accept this, that because of the technological advancement, we have stopped talking to the patient. Patient has lost confidence between a doctor. So there is no confidence between doctor and a patient, and totally there is a mistrust has developed in healthcare system. So how to revive that? How to take care of this? So I think possible answer is palliative care. And palliative care simple philosophy is it's not very new. It's a simple philosophy to take care of the patient who is not going to be cured. We are not going to desert this patient. We are not going to enhance something to finish this patient. But what we will do, we will take care of this patient. Something is wrong? You have to tell them something is wrong, slides are not moving. Hello, sir. Slides are not moving. Anyway, without slides also I speak. So, philosophy of palliative care is very simple, which we have taken the oath when we were becoming a doctor, that we are not going to treat a patient who is overmastered by the disease. It does not mean that we are not going to treat a patient as such. We are going to take care of this patient who is overmastered by disease, but we will just care this patient. Care in the sense, if there are any physical symptoms, we will take care of this patient. If there is any psychological, social or spiritual symptoms, we will talk to the patient, we will consult the patient, we will try to explain the patient about the disease status, but we will not leave this. So this we have already taken this oath, but we have completely forgotten this oath. So exactly what exactly this is? So this is a simple definition which was which came from WHO in 2002, that this medicine is to improve quality of life of patient and their family members. Please give attention that it is not only to the patient, but it is to the family members also. The patient, those who are facing with serious life-threatening illnesses. We know there are spectrum of disease where we can say that these are serious life-threatening illnesses. And what we will do in palliative medicine, and if you will integrate this concept in your day-to-day practice, what you will do, you will early identify the impeccable symptoms, and you will early identify and assess those symptoms and treat those symptoms. And most common symptoms which we are know, at least in cancer patient, that pain is the most deadly, and pain is the symptom. You must have seen so many patients dying in cancer with severe intractable pain, unaddressed pain, and you know, when patient is in pain, the whole family members are suffering. So in palliative medicine, if we will integrate this concept, we will be bound to relieve the pain. We will be bound to relieve the distress of the patient, those who are suffering with cancer or any life-threatening illness. But we will not do something to prolong the life. We will not do something to prolong the suffering. Life is important, but we will not do something to prolong the suffering by putting this patient in ICU or on ventilators or on vasopressors or on others, this thing. So this is simple definition, and this slide is very, very important for all of us. We know King Ashoka. So basically the concept of palliative care, as today is also the day of I think Parents Day. Today is also Parents Day. So we know that since ages we have a habit of taking care of our parents and elderly, grandparents and everything. This is deep rooted in all of us. But you know, somehow in medicine, when we talk about medicine, we have completely forgotten this concept. And that's why the King Ashoka has made almost 18 institutions near Gangetic Plain. And these institutions are still there, and these are basically similar to modern hospice. If you will go to St. Christopher Hospice, it is just a maintained the hospice which King Ashoka has made in the Gangetic Plain. Only thing, nobody has given any attention that he has already made this, that, and where refugees and the people, those who are dying, they used to come, they used to take rest, and there used to be people, those who are looking after those patients. They used to give them relief, they used to take care of their wound, they used to take care of their bed sores. So it was already there in 273 BC. Imagine this concept was there in our India, but we have completely forgotten. Now we should not feel guilty about it, because this is also not a very old concept. The all over world, this concept has come by this lady, and we should remember this lady, that is Dame Cicely Mary Saunders. And you know, in 2019 she was born in 1918, and somewhere when she was 40 or 50 years old, she realized that a dying patient who is dying with serious life threatening illness, they need some kind of a different approach. They don't need approach similar which we are taking for all the patients. All patients, those who are dying, we are taking the same thing. We are resuscitating, we are putting them in ICU, we are doing everything. But what we are not doing, we are not relieving their symptoms. We are not talking to the relatives. We are not giving them honest information. We are not giving them realistic hope. So this lady has realized and she has given this concept of palliative care. Now, what are the milestones in India? So we should not forget, we should not again feel guilty, because in India, it has come in 1986, almost when we have finished our MBBS. So, Seema, me and Jagdeep, we have started in 81 and we finished our MBBS in 86. And that time this concept has come in India first time by a colorectal surgeon, Dr. D. D'Souza. So he was the person who has first built the modern hospice that is called Shanti Avedna Sadan in Mumbai. Again, almost 10 years, nothing has happened. And in 1993, when we finished our MD, in 1991, when we finished our MD, that time this concept has come, first time Pain and Palliative Care Society established in Kerala. So that it is not our fault. It was not there in our MBBS curriculum, it was not there in MD curriculum, and it was not there in the air of India. So first time in 1993, Pain and Palliative Care Society was established in Kerala. In 1994, first time Indian Association of Palliative Care as built up as a public trust society, first time in Ahmedabad. And in 1994, first international conference happened at Varanasi. Now in 2023, it will be 23rd or 24th conference at Bangalore. And you know, in 2012, Medical Council of India first time realized that MD palliative medicine is a separate specialty and we should have a dedicated MD palliative medicine. So in 2012, Medical Council of India has recognized palliative medicine as a separate specialty, and now various hospitals are having MD palliative medicine. But when we talk about Delhi, it is only there in AIIMS, New Delhi. Why? Since 2012, all over Delhi, various hospitals has not realized the need of starting MD palliative medicine. In 2014, amendment of NDPS Act has happened. NDPS Act is Narcotic Drugs and Psychotropic Substance Act, where we found that medicinal use of opioids are important to give pain relief to the patient, those who are suffering with serious pain because of cancer or other chronic diseases. But it was not available. But amendment has happened in 2014. Any hospital in the country, those who wants to treat patients, those who wants to give pain relief to the patient, it is a simple law, simple rule that you have to just approach drug controller of your state, that is in Kadkad Guma drug controller of our state sits. Just you have to send an application that we want to treat cancer patients or we want to treat cancer pain patients and we want so many tablets, and that's all. So there is a simple rule is there. Then in 2016 AIIMS started. So 2012 Medical Council of India has recognized, and 4 years we took and we started MD palliative medicine in 2016, and in 2021 DNB palliative medicine also started. So imagine this. So all the development, I have brought this slide to just to make you feel not to this thing that why we are not knowing about this concept, because this concept is new in our country. Now this is very important slide. This is very important slide. This is an important slide in the sense that palliative care most of the time is misunderstood by end of life care, but this is not the truth. This is basically continuum of care. Continuum of care, I gave you an example. A patient who is suffering with carcinoma breast, once she has been diagnosed with carcinoma breast, in the early stage she wants to know everything about the carcinoma breast. So a surgical oncologist or medical oncologist, those who are looking after this patient, they should have full knowledge that how to address all the unanswered question to this lady. So initially it will be curative care, definitely, And as the disease will progress, if is some kind of a triple negative cancer or something, and if disease is progressive, then slowly there will be minimum disease directive treatment, but palliative care physician will start taking the lead. So if your hospital have a dedicated palliative care program, it is not that since the beginning they will involve, but as the disease will progress, patient will start having symptoms, minimum disease directive treatment will take the lead, and palliative care physician will start taking the lead, and they will start treating intractable symptom of this lady. And as the disease will progress, when the end will come, then there is a good palliative care setup in your hospital, and patient can end their life in a dignified way without going into ICU with complete symptom management. So this is what I am saying, that there should be a dedicated palliative care program in all the hospital, and then you will be having a good end of life care tactics. You will have a good end of life care policy in your hospital, and you will be able to provide dignified end to all these patients. And there are ample evidence there are ample evidence, and this was the first paper published in New England Journal of Medicine, which was very landmark publication in 2010, and which says that this was a paper on non-small cell lung cancer, and what they have done in two groups. One group, they have integrated palliative care program right from the beginning, and in another group they said that palliative care as well as curative care, without curative, only curative care. And what they have realized, that the patient, those who were receiving palliative care right from the beginning, they were having good quality of life and less chances of aggressive treatment. There are other evidence, all these evidence, and they says that integration of palliative care leads to fewer hospitalization, decreased cost, increased satisfaction, improved quality of life, and increased satisfaction not only amongst patient but caregivers also. So how important it is to integrate palliative care in various hospitals. And this is a very important paper again published in JAMA, and this says that palliative care not only improves the quality of life of a patient but also the caregivers. If we integrate palliative care in the continuum of care, there will be 9-fold decrease in grief disorders. But if we will not integrate palliative care, there will be 9-fold increase in grief disorders. Means patient, what exactly this means? If a poor patient, if we are not able to explain to a patient that this is a terminal, some kind of a terminal illness where ICU is not required, it is just we need a symptom management and care to the patient. If we will not explain to a poor patient, what he will do? He will go around and he will search ICU bed, and when he will not get an ICU bed, he will keep on feeling guilty that my patient died, my wife died because I was unable to give the ICU bed. A middle class person will again struggle. Middle class person will sell off their property, and then they will get the ICU bed, and then they will be dropped because doctor has not explained that ICU was not the answer at this stage. And similarly, a very filthy rich man, they also die in suffering in ICU because there are so many examples. I will not take the name of over here, but all our famous leaders, all our famous professors, famous doctors, those who were, we knew that they are not going to, we will not be able to do anything to prolong their life, but ultimately they have spent their last stage of their life in ICU, in ECMO, on ventilators. So everybody is dying and suffering, but we can reduce these grief disorders, grief, bereavement, grief to the relatives by providing them honest information and realistic hope that ICU was not the answer of this end stage of the disease. I hope I am understood. So what extra we need to learn and teach in medicine? So I say that medicine is incomplete if we will not teach to our undergraduate and postgraduate the concept of palliative medicine. So what extra we need to teach? So we know expert symptom management. We have to give realistic hope. Hope is a good therapy. Hope is therapeutic. Initially, hope should be there to cure. But when cure is not possible, you should start giving hope that we are giving treatment to that disease should not progress. And then as the disease will progress and patient will come in advanced stage, we should give hope that your patient, we are taking care of your patient, and we try to reduce the symptoms, and we try to give the dignified and peaceful end. So hope should be there, but it should be realistic hope. you should have a habit of giving honest information. Honest information, actually, ma'am, we have written a paper on this, and this paper was very famous, that who is not brave in medicine. And what we have found, that doctors are the, means like they don't have a courage to explain to the patient that we have reached to this disease, has reached to the stage where nothing, or we are not doing anything to cure, and ultimately the disease is declining. The relatives understand because the patient is declining. Only thing they want endorsement from you, that you should explain to the patient. And you should also know how to facilitate the complex decision making, and you should have a good learning or communicating quantity versus quality of life. Quantity is important. Everybody wants to live 100 years or 110 years, but if it is at the cost of worse quality of life, severe pain, unnecessary dying in ICU with, you know, in ICU both the hands are tied with both the hands are tied, there is tube, there is Ryle's tube, there is a urinary catheter, then we put pleural catheter also if there is pleural effusion. But if a patient is having brain meds, liver meds, lung meds, bone meds, everywhere meds are there, why we are putting this patient in ICU? Rather than we can give good quality of life by providing pain management, symptom management, realistic hope and honest information. So what steps we have taken at AIIMS? We have started teaching this, so we got 5 lectures in UG program. We started MD and PhD program at in palliative medicine. We have included palliative care in DMG and screening in cancer in various National Cancer Institute and at IRCH. So there is a screening team where radiation oncology, medical oncologists, surgical oncologist and palliative care physician all sit together. And if a patient, most of the patient, they come in advanced stage. When they are coming in advanced stage, they get registered in palliative medicine. But it does not mean that other people will not treat. Other people, there are many cancers like C ovary, lung cancer, certain kind of lung cancer, they can be treated. So other people will also give treatment, but first we give pain management. We start giving realistic hope. The disease has reached to this stage, we are starting treatment. So this is the practice at National Cancer Institute as well as at IRCH. All 4 people, they are seeing patients together in the screening. There is an ambulatory palliative care team for all over Delhi, all over AIIMS. All over AIIMS means other branches like neurology, pulmonology, wherever there is a need, we go there, give pain management, we give end of life care counseling and consultation. There are rotational posting of various departments, gynae oncology, ENT, pediatric oncologists, all of them are coming to palliative medicine to learn what? To pain management, symptom management, counseling, communication skills. So they are coming to our department to learn all this. Academic activities and joint teaching sessions are happening. Dr. Mamta is here. We have recently had a joint teaching session in neurology department, and she wanted to integrate palliative care in patients with epilepsy, and you will listen to her experience and during the panel discussion. So we started a joint teaching program. We have a habit of taking regular audit what we are doing. So in our own department, we take audit monthly. Yesterday only we had an audit, and we listened to the residents that how many patients they have seen in neurology, pulmonology, emergency medicine. Dr. Praveen Agarwal is here. We have integrated program of palliative medicine in emergency department, because emergency is a place where most of the patient we put in on ventilators. But we are trying to teach emergency medicine residents that when and how we can avoid unnecessary intubation, how and when we can avoid unnecessary transfer of ICU. Otherwise, what will happen? You know, our 30 to 40% of beds of all over Delhi, if you will count in Delhi today, 30 to 40% of beds are filled up with those patients, those we all know that they are not going to revive, they are not going to come out. And those patients, those can be revived or those can be survived, we are not getting ICU beds because we have filled our beds with the patient, those we all know that they are care. So we can utilize our resources judiciously by integrating palliative medicine in continuum of care. And we have a good home care team, and there is one home care doctor is sitting over there, Can Support and Can Kit. These are the 2 where we are very lucky in Delhi, where there are 2 very good NGOs working all over Delhi and NCR. So if you are sending your patient, empowering family members, that this is the way you are going to treat your patient at home, The home care team will go and see those patients, and they are going to talk to you. If there is a need, they are going to talk to you that this patient is or whatever, if their consultation required. So this is the way we have improved palliative care services at AIIMS. These are the scope of palliative care, and you will listen in the panel discussion that how all these branches we have integrated immensely, and we are successful, and this is the way we are giving good quality of life to all our patients, those who are registered in AIIMS. So this is an integrated program of palliative care. This was published, we have published in Indian Journal of Medical Science. These are the 4 important contributions I can say from AIIMS to the medical science, or we can say to development of palliative medicine. That department, our department is ESMO recognized palliative care center, and it has become WHO collaborating center for teaching and training of palliative care all over India, so and CRO countries. So we are like now WHO has also endorsed our teaching and training activities, and they have asked us to develop the modules for not only India but all over CRO countries. And we have developed pain policy, and we have end of life care policy. I will come back to this. What is pain policy? This is a policy which gives our patient, this policy mandate at AIIMS that all registered patients, those who are registered in AIIMS, and if they are in suffering with some kind of a chronic debilitating condition, what we do, we sit down with the relatives. We first, there should be a consensus amongst the physician, the primary physician. For example, a primary physician is an oncologist. Oncologist will say that we have reached to a stage where curative treatment is not going to be helpful, and once they say this and they call the palliative care physician, we take the similar meeting with, this is called family meetings. We will have family meetings. So we will call family members, and we say that all the family members, those who are lead person of the family, there are always lead people in the family members, sometimes husband, sometimes son, sometimes father. So lead people, they should come, we sit together, we try to explain them that unfortunately disease has reached to a stage where we are not going to do anything to cure the disease, but we are not going to desert your patient. We will treat the symptoms, and these symptoms can be treated at home, and this is the way we are teaching you that you can take care of the symptoms at home. Most of the time, 90% of the time we are successful. Relatives feel empowered because everybody wants to take their patient at home, and they take the patient. But 10% times when they don't feel empowered because of various reasons, we try to keep the patient in the hospital, but we don't put this patient unnecessary in ICU. We give symptom management, and we give dignified end to the patient. So this is the way you should read this paper. This is just published in Indian Journal of Medical Research. In February issue only. You should read this paper, and you should feel empowered that how AIIMS has adopted end of life care policy, so you can also do the same thing. Second thing which we have done is pain management policy at AIIMS. Means all the registered patient, whether they are indoor patient, whether they are OPD patient, or they should be pain free. We have developed the nursing chart where we have taught almost all our nurses that pain should be treated as a 5th vital sign. We take blood pressure, we take heart rate, we take respiratory rate, but they also measure pain when they are on the rounds. So even a simple pain, if patient is having, we try to address that pain. And what is our policy, that the mild to moderate pain should be treated by primary physician. This we are taking classes during the entry of the residents. When they are entering, we take counseling classes. That time we are teaching them this is the way, these are the policies which are available in AIIMS. And once the pain is intractable, then we have a pain resource team. There is a pain resource team in main AIIMS, there is a pain resource team in trauma center, there is a pain resource team in IRCH. So we try to address the patient's pain when pain is intractable. So imagine, if you're in the hospital, we know that there are many patients, multiple patients, they remain in pain. A pain because of thrombophlebitis, if we give a wrong this thing, extravasation patients really feel pain. Pain because of the intramuscular injection, pain because of the bone marrow aspiration. This is so severe pain, but we don't address those pain. These are simple pain. But if severe pain there is in cancer patient, they almost, and you know, the incidence of treating cancer pain in India is less than 3%. So many doctors, you all are very intelligent, very learned people, but this is an eye opener that we are treating only less than 3% of cancer pain in India. Rest 97% of our patients are dying in pain. So this is a high time, and I am very happy today we are here that we will try that this percentage should increase. For capacity building, I am also president of Indian Association of Palliative Care. We have started multiple programs. This is one program, that is Cancer Treatment Center program, and you know, in this program we have reached to 22 states. That's why I was very upset that Delhi is not there. I tried to approach many Delhi hospitals, but I was never successful. So Delhi, only Safdarjung Hospital has a dedicated program. Max Hospital has a dedicated palliative care program because our students are there. In Safdarjung Hospital, Dr. Savina and one of our students, they have started because they have realized this is important. So wherever our students are going, they are trying to develop these programs. So even in the corporate hospital, Dr. Megha and Dr. Gaurav, they have started. But in these states, we have started with this program, institutional based dedicated palliative care program, and that is why I really want that Delhi hospital should come forward. They should get enrolled in various programs so that they can start integrating palliative care. This is very important slide that we give a lot of emphasis to teaching our nurses, because nurses are the backbone of the system. So once you will teach your nurses that this is the way, because you know, you will take the rounds, you will give the orders, but if you will not teach that how to give opioids to the patient and what is the thing to monitor this patient, when your patient is on opioids, your attempts are failed. You just cannot be all the time with the patient. So it is very important to teach and train your nurses. So we give a lot of emphasis, and for this we have started this LNEC program, and you can see that all over country we have reached with a dedicated program, and this program, it's very, very successful. Wherever we are going, all the nurses we are trying to teach, almost all the nurses. We create trainers in the hospitals. We have reached to various states. We create trainers in the hospital through their teaching, nurses teachers, and they are teaching, in turn teaching to other nurses. Other activities, this is just very important that right from the, to start with, you can start with this certificate course in Essential of Palliative Care. This is a very simple course. 3 days you will have to be online. Then after 3 days, you get 6 weeks, and you will get this book. This book we have created ourselves in Indian Association of Palliative Care, and we say that this is Oxford textbook of palliative care in India. This is in a simple language. All the basic concepts of palliative care is there. So once you will enroll in this program, you will get this book. When you will read this book, after 6 weeks you will have to give an exam, and in this exam, very simple exam, short answer questions, MCQs, and once you will pass this exam, you will have to do part B. Part B is, there are 45 centers all over India where you can go and learn practical training for 10 days. Once you get part A and part B certificate, you are authorized to start at least basics of palliative care. You are authorized to take RMI certificate. RMI registration means your hospital, you can go to drug controller of your states, and if you will say that I have already completed part 1 and part B, these are my certificates, then drug controller of your states will understand that yes, this person, this doctor is already having training how to prescribe opioids and how to monitor side effects. Then they will easily give you this certificate to procure opioids and dispense opioids for your patient. So almost 5,970 doctors we have trained, and nurses 3,300. So these are last few slides, 2 or 3 slides, that in 2021, we again in 2015 we had this quality of death and dying ranking. This means in 80 countries we tried to see that how people are dying in various countries. That time India was in 2015 in 67th position. In 2015, In 2021, I was also part of this task force, and what, in spite of my best efforts, they took all sorts of interviews from various nurses, doctors, patients, relatives, and what we have found that still we are lying on 59th position. So this means India is not a place to die with dignity. And the top people, top countries, those who are having the best quality of death, they were having integrated palliative care program. They, all the doctors, those who are getting trained in undergraduate and postgraduate, they know that if patient is suffering with some kind of a chronic illness and patient is at the terminal stage, there is no need to put this patient on ventilator. There is something else we have to do. We have to explain to the patient, and we have to give symptom management. So it's again an eye opener that we are still on the 59th position and we have not improved. So we should improve, at least in Delhi. If somebody will do quality of death index, after 5 years or after 3 years, Dr. Tyagi is here, Dr. Jyoti is here, all leaders are here, sitting here. At least in Delhi, we should commit that quality of death index will be better in Delhi after 2 or 3 years, and we are ready to help you. Ultimately, a patient who is suffering, at the end, they just want the information on current status, what is the disease status, what is the future course. They want honest information from you. They want realistic hope. They just want freedom from pain and symptom. They don't want anything else. They just want your empathy. They don't want sympathy. They don't want sympathy, and you are giving sympathy and putting the patient on ventilator, asking them to arrange money for ICU. I think they don't want this. So these are the things which a patient want, and this is the way I have just brought 5 points. This is the way we can integrate palliative care in Delhi hospitals, that we have to integrate in UG curriculum. We have to start MD palliative medicine program. IAPC basic course in various hospital we can start creating trainers so that they can train. And this is again a slide which is again an eye opener. If tomorrow these kind of children you must be seeing in your day-to-day practice, but how you are managing their pain. If you don't know how to prescribe opioid to these children, you will not be able to manage pain, because paracetamol and ibuprofen paracetamol will not help. Tramadol we cannot give in this age group. You need to learn how to give morphine and fentanyl to these children. And this is the reason that this is the circle which we have created and published. This is the circle because we keep on thinking that opioids are just to misuse, it can create addiction, but there are 10 steps which can give you a clue that how to use opioids safely, by just developing trust, creating awareness, empowering physician, assigning responsibilities, making it available all the times, and other things. So this is just to say that capacity building is like nurturing tree and growing a tree with a good root system, and we are here to develop capacity in Delhi hospitals. We have to assess what is our stage. We have to develop some program. We have to implement, and we have to develop a sustainable system. Tomorrow, AIMS has a dedicated program, whether I am there, whether my colleagues are there or not, but the system will always remain. System of dying with dignity will always remain. And this is my take home message, that medical science is incomplete without learning integration of palliative care. It is a extension. We have to, it is not only for cancer patient, it is not end of life care. We have to create awareness. We have to teach our residents that humanity is a wonder drug. Empathizing patient, giving realistic hope and honest information is most important for patient at the end. And we have to learn safe use of opioids. This is me. When my mother died, Seema was there with me, and we have not put her on ventilator. We have not put her on any vasopressors. She died in 5 days. We knew that she is not going to survive, and we were all 4 brothers and sisters were there, because this system we have created. Tomorrow if I will be suffering with any chronic illnesses, my junior colleagues, my residents, my doctors, they know that there is no need to put her on ventilator. There is no need to send her in ICU, because this is not the system which we have created. Rather, they will give me symptom management and send me home with my husband and my children. Thank you very much. So you have to create a system. So now we have I think I have taken a lot of time. But we have started late, I think. 15 minute late start किया था. But we will start. चलता है. Mic दे दो हाँ. So till the time mic comes, I have a mic that Dr. Nishkash and all my colleagues, he will introduce colleagues and we will have a good panel discussion. And I think Nishkash, you will introduce? Come.
So may I, madam? Dr. Seema?
Yes,
First of all, I want to congratulate. Let me introduce myself. I'm Dr. Chanchal Pal, Senior ENT Consultant at Apollo Hospital, Indus Apollo Hospital, and President IMS South Delhi branch. I am so impressed by your talk, clarity of your talk, and passion you have for the subject. So I thought it may not be inappropriate for me to get up and say so. It is a very important subject, and I congratulate organizers also to bringing up this subject, which is important. And also will like our hospitals and will like to know how we can convince our hospital. Only one question I like to know that what you, just one question. Thank you.
अच्छा
Okay, sir.
ठीक है
Thank you.
आप अपना क्वेश्चन बोल दीजिए we will discuss that.
I just wanted to know whether how to convince the patient that we have not done enough, or is there any law
We
to
will come
protect
back.
us?
We
Yeah,
will
thank
we
you
will
so
we
much.
will address
Thank
this
you.
question. Thank you very much, and we will. I think all the questions, questions should be asked after this panel discussion. So probably all the answers we will get in the panel discussion. Thank you.
अच्छा हाँ ये भी है तो उधर ही बैठे रहने नहीं फिर मज़ा नहीं
सुनो चेयर्स तो और चाहिए.
Before we proceed, I would like Dr. Girish Tyagi to please come on the stage, Dr. Girish Tyagi, and hand over the memento to Dr. Sushma Bhatnagar. चेयर कंफर्टेबल में लगा दो 10 मिनट का ब्रेक चाह रहे थे हम लोग.
फिर ये वापस आने में बहुत टाइम लगेगा.
हम शुरू
ओके तो
सॉरी
सर आ जाइए.
सर आइए.
regarding Dr. Sushma Bhatnagar patient, because we both were involved with the Delhi government, have a series of meetings in which the various modules were prepared for the about the palliative care in Delhi government hospitals. But ultimately they, because few days back when I was asking Dr. Sushma Bhatnagar कि Delhi government में क्या हुआ, Dr. Sushma Bhatnagar told me that Delhi government में the position same की same ही है, except for the Safdang hospital and AIMS there are two government hospitals where the palliative care. So this is, but the Sushma Bhatnagar is very emotional, very caring for the palliative care and totally involved with the dedicated. So and once again congratulations ma'am. Now we are breaking here for 10 minutes break for the tea break, because few of our delegates have come around 3 o'clock or so. So it is exactly that 10 minutes break. After 10 minutes we will assemble here and the panel discussion will start. Thank you very much. He is a faculty at Department of Radiotherapy. Dr. Vijay Hadda, additional professor at Department of Pulmonary Medicine and Sleep Disorders. Dr. Rakesh Garg, additional professor, Department of Onco Anesthesia and Palliative Medicine. Then we have Vinod Kumar. Vinod, idhar aaja. Acha naam to. He is additional professor at Department of Onco Anesthesia and Palliative Medicine. Dr. Brajesh. Brajesh is assistant professor at Department of Onco Anesthesia and Palliative Medicine. And finally, Dr. Mamta. Dr. Mamta is professor at Department of Neurology, and she is actively doing a lot of epilepsy work there. So the title of panel discussion today is Integration of Palliative Care, a Necessity for Comprehensive Care. So please settle down. We have started and will if we settle down fast, we'll be doing it in a time which is allotted to us.
प्लीज
Please settle down.
सब चुप हो जाओ, बहुत मजा आने वाला है, चुप हो जाओ सब, एकदम से चुप हो जाइए प्लीज.
So now,
आते जाओ बैठते जाओ लेकिन बात नहीं करो. We are starting.
so
Good.
to start with this, so for the first important question which comes to us when I joined in 2012 in All India Institute as a faculty. So I was really confused. So what is palliative care? Was it a therapy or there's an outlook to the looking at the patient? And who should be the person to initiate palliative care in patients with chronic disease? Shushma ma'am, kindly enlighten on this.
सबसे पहले निष्कर्ष ने बताया 2012 में जब इसने ज्वाइन किया डिपार्टमेंट, so we were having already the department, means like we were having services, palliative medicine services we started, and now the question came that who should start palliative care. So any doctor, nurse, any person can give palliative care, but there is a role of doctor, there is a role of nurses, and there is a role of volunteers. So there is a dedicated role of everyone. So any patient, any person who understand the need of a person, any person who has an attitude, who has a human touch to a person who is diseased, who is suffering with chronic debilitating condition, can start palliative care program and can give palliative care. Only thing, we need to have a basic understanding of symptom management. We know the symptom management, we know how to treat nausea, vomiting, pain and all, but we have to apply whatever knowledge we have in the right context. We have to improve our knowledge that how to use other medication which we are not using routinely. So this is what extra we need, and we can start at least basic symptom management to the patient, those who are suffering with serious health related disorders.
Thank you, ma'am. So when we were students, no, we used to read about WHO definition of health, and it used to be comprehensive care, including complete social, physical, and mental well-being. And so believe me, so as medicos, though we are being taught, but we are not taking comprehensive care of the patients, and palliative care is a part of a comprehensive care of the patients, and it needs to be done in whatever form is possible. Dr. Dev, unfortunately, is not here. He's stuck up. So what is the cancer burden in the country? So we know there are we have about 140 crore odd population, and the cancer incidence is increasing day by day, and we have a lot of malignancy which come advanced to our setups for a lot of reasons, including limited facilities available. And these patients do need addressing the symptoms, and the need for palliative care is much more nowadays than it was there when 20 years down the line. So now next question comes to our mind is that, so what is actually the integration of palliative care? So how do we actually do it? So do we have a specialized palliative care services at all the centers, or can we do without a specialized palliative care physician at our setup? Dr. Seema ma'am, please.
So when we in the Dr. Shushma's lecture, you must have heard, I think, numerous times the integration word. The word integration, it has come again and again in fact in every 3-4 slides that she was talking about. The integration is much more important. When we go the meaning of integration, sometimes it is very difficult to really understand what is integration. But I will try to make you understand what is the integration. When we want to take care of the patient, especially in the palliative care concept, we have to integrate in each level, not only the clinical aspect of the care. We have to be integration like in administrative level. We have to provide that service level. We have to not only the clinical level, we have to integrate with other physicians. So integration has a different aspects. Each and every level we have to integrate. So that is the meaning of integration. And why we need integration. So far we have come to know that this integration is going to help improve the symptom burden, what we are taking care of, improve the quality of life, decreasing the suffering, improve the end of life care of the patients. In fact, if you provide the integration of the palliative care in different aspects, it is going to survival also will increase. In many slides, Dr. Shushma has really shown that it started from 2010 that one literature it starts that if you integrate the palliative care services in the early integration in the clinical care of the patients, especially that malignancy patients, it is going to prolongation of the life also. So quality of the life also it's going to be there. Not only the, we always talk about quality of life, but we never talk about the quality of death. And in ma'am's lecture, you must have seen the quality of death index. So it is not only the life we have to improve, quality of life, we have to improve the quality of death also. So you know, the death, if any, I think everyone must have seen the death in their near and dear ones, some or other, grandparents, grandparents. If they have suffered for a longer time, and it is just not only it's the death time, it remains in your brain and the heart. If they have suffered a lot, if you can think of it, if there is palliative care services, if somebody had really given the palliative care in that time, end of life care, it would have not remain your head. You have, must have good memories. Death is ultimate, so whosoever has born, it is going to die some or other time. But that path, that total journey, if you are going to improve upon it, it is going to be really helpful for all of the human beings.
Thank you, ma'am. And what about, do we need a specialist palliative care physician at each setup, or can we baby steps can be taken without a palliative care physician who is trained in MD?
I think half the answer has already been given by Dr. Shushma. When we say that palliative care, who should start? Anyone who has an attitude to learn, especially in the medical fields, whether it is doctor or it is nursing staff, if they have an attitude to learn how to really improve the quality of care, it should be started from that. If we wait for that specialist palliative care, it is very difficult to provide that. Such a huge country we are having, that number of our age, you can just see that how many people, our population is so much. So if you can wait for only for specialist palliative care, they will provide the palliative care. It is very difficult to give the palliative care, and already has been seen that only the less than 1% of population we are able to provide the palliative care. So that is the reason we want to integrate. It's not only in organization we want to integrate from the NGOs, we want to integrate so they can provide the palliative care in the community levels. We want to integrate the primary level services, we want to integrate the secondary level healthcare services. So we have to integrate, and then we cannot wait for only the palliative care, specialist palliative care. But yes, the responsibility of specialist palliative care is there. They have to educate, they have to active participation in the awareness. This is one of the type of awareness which we are doing today. Providing the knowledge, what is the palliative care, how we can do, when we can initiate like this. And obviously the training programs, the various training programs, Dr. Shushma, she has mentioned in the lecture, she has shown how many training programs are there in our country itself. If we don't know what are the training programs are there, we cannot really want to involve ourselves in the training program. So education, awareness is very, very much important. So everyone can take parts in the palliative care service if they want to really have an attitude of it. Thank you.
Thank you, ma'am. So actually, you are absolutely right, ma'am. So basically, it is an important component of the comprehensive care of the patient, and each and every one of us have our role, and we have to play our bit in building up the capacity and giving comprehensive care for the patient. So now there is a typical case. No, this is a common feature at our hospital. We have a 45-year-old female perimenopausal, and she complains of pain lower abdomen for 8 months, difficulty in breathing for 3 months. There is lower limb swelling, and there is passing of fecal content while urinating. So basically, typically CS cervix patient which is advanced, and we know it is one of the commonest malignancy in the country, and we have a lot of patients who come in an advanced stage to us. So now the question is that Dr. Saini, he is from radiation oncology with us. So what are the common signs and symptoms seen in patients with advanced gynecological malignancy, and when we actually decide to refer them to a specialist palliative care physician? Dr. Saini, please. Dr. Saini? So what are the common signs and symptoms seen in patients with advanced gynecological malignancy, and when do we actually refer them for a specialized palliative care services?
The most common symptom for which the The most common symptom for which patient usually seek attention, want to seek attention of a physician is pain in gynecological malignancy. Usually 70 to 90% of the patient have a severe pain. It is to be noted that the pain is due to the infiltrative nature of the malignancy and secondarily due to the pressure effect. The other symptoms related with the gynecological malignancies are the foul smell and vaginal discharge, and bleeding PV is also a symptom in late stage disease, usually in 20 to 30% of the patient. Other symptoms related with the gynecological malignancies are disease specific, like carcinoma ovary. Patients have a symptom of abdominal distension that may be due to the intestinal obstruction in recurrent or advanced disease or due to the ascites. And it may also present in carcinoma of endometrium. And patient of carcinoma vulva have disease, pain is the common symptom with the vulval disease, as well as the foul smelling. And the referral, as per referral for these kind of patient for the palliative care, there is no such a guideline, but for the universal screening, specific palliative care should be, the patient should be sent for the palliative care physician opinion for the universal screening of the symptoms, especially the pain and other symptom. And whenever there is a increased symptom with the advancement of disease, it is always necessary to seek opinion of a palliative care physician.
Thank you, Dr. Saini. So yes, so it is well known that in patients who have advanced disease, the quality of life of patients is poor, and they actually need more aggressive management of the symptoms and their emotional and physical functioning rather than the disease per se. So that needs to be taken care of with the help of giving patient, listening to them, finding what are the more common symptoms and trying to address them at local level, and maybe an expert help may be needed depending on the feasibility. Now, initially the palliative care was kind of introduced on malignant diseases only, but there are a lot of non-malignant diseases we are seeing nowadays, and we know the burden is much more, and be it cardiovascular disease, be it pulmonary disease, be it patient coming to emergency for various things, be it a neurological disease. So the burden is too much for the patients, and most of them, like maybe it is COPD or a stroke patient or other chronic disease, mostly they are not curable, but at most you can limit the disease symptom and the duration. So now these patients often come to the emergency, and it becomes tricky to kind of decide whether this is the final kind of exacerbation of the chronic disease the patient is suffering from. So Praveen sir, how do you actually come to this point that when should you actually discuss end of life care with the patients who are coming to emergency?
I just give you my experience. Till about 1.5 years ago, we were intubating almost every patient of disseminated malignancy who comes with the respiratory distress, every patient of COPD coming with acute exacerbation, even if he was terminally ill, every patient of heart failure, terminally ill heart failure patient coming in respiratory distress. We were intubating all these patients in emergency. But right now, in the last 6 months or so, because of training of our residents by palliative medicine department, we are able to not intubate the many of these patients. We so-called do not intubate the patient, do not resuscitate the patient. And I would say almost every second day, we are able to not intubate one of these kind of patients. So that I would say is a great achievement from our department, that we are saving at least one ICU bed almost every second day.
Thank you, sir. So, so how do we actually decide the appropriate time? So mostly they will be coming for the first time to the emergency, and it may not be the right time to initiate. And how do you actually balance the things?
Yeah, that is a little difficult decision, because many times the medical details of the patient are not available to us. They come with incomplete history, incomplete medical details. So that time it becomes very difficult for us to decide whether this is really end of life care or not. So then we take our own decision. We generally do all the resuscitation procedures, including intubation also. But if we have all the details available with us, then we discuss with the family, and in case they agree, then we try to avoid the resuscitation part. We just do the palliative part only.
Ma'am, you want
Can
to?
I add?
Yes.
So I think this is very important to understand. The Dr. Praveen is heading the Department of Emergency Medicine at AIIMS New Delhi, and you know he has said that at least alternate day we are saving at least one ICU bed by understanding concept of palliative care. We are explaining to the patients and their relatives, and then Nishkarsh asked that how you are deciding. So this is going to be a difficult task if we will not integrate concept of palliative care in our hospital. But what we have decided with Dr. Praveen, that we will develop some kind of a mechanism that those patients, those who are suffering with chronic illnesses, so all the departments will be having a, the patient will be having a separate kind of a card or separate kind of a document where we, because this type of discussion should start happening long time before the death comes, because once the patient is coming in gasping stage in the emergency and you will not intubate, this will, he will not understand, he will say doctor has not done anything, and then everything, all illegal and legal things will start, that they have not done, they have not complete, they have not done the job. But if a doctor from a ward, when they are coming for consultation, they will start explaining this, that some kind of your disease has reached to this stage where you may land up in difficult symptoms like respiratory distress in emergency. That time we should not opt for intubation, rather we should just opt for the symptom management. I think that will be the situation where we will have a complete integration, and we are trying to develop this kind of a system for emergency.
Thank you, ma'am. Thank you. So now, most of the chronic disease, neurological disease are more debilitating. And Dr. Mamta, Professor Neurology, CN Center, AIIMS is with us. Ma'am, what is your experience regarding the symptom burden, and what does worry you most as a senior neurologist at the institute? Yes.
Yeah. Thank you, Nishkarsh. Are there any neurologists in this hall?
Do we have neurologists in the hall?
No.
Not
Okay,
many.
Okay. So, as a neurologist, there are a lot of diseases for which we have excellent care, and over the years, over the decades rather, I've been at AIIMS for the last 20 years. Care in most diseases has improved. Having said that, we still have a large number of diseases where we cannot claim to really have cures, and even without actually calling it palliative medicine, what we actually do is symptom control. So I think palliative medicine, while it's very nice to have, you know, very senior experienced people who are just so focused, as Professor Bhatnagar, Nishkarsh, and you know, in their department, they are just focused on palliative care. But I really feel, especially when we look at the numbers in the country, that each one of us, irrespective of what they do, has to have a fair understanding of palliative care, and it will have to be integrated. So the day you are, for example, diagnosing Alzheimer's, even if it's, you know, early Alzheimer's you might know is one of the causes of dementia. So even if it's very early and you know that the patient may take, you know, a few years to actually worsen and lose their faculties, it may be the right time to also, you know, even at the beginning start discussing and offering services which may be a part of palliative care. So neurological diseases also are very peculiar in that in some of the diseases you see patients do not have use of their higher mental functions. So if a person, for example, is not recognizing her husband, her children, it's a very sad state. So neurological diseases may not imminently kill people. So it's not like a cancer and you know you have a grave prognosis that the person is not likely to be there in the next 3 months or 6 months. But the person may linger on for some years, sometimes even longer, but they are increasingly not fit enough to take care of themselves, even think for themselves, and they require support of all kind. So in these patients, if you think of palliative care as comfort care, I saw that in one of the slides, I think that fits the bill. And probably not just neurology, but most other specialties will also have a lot of need for this kind of comfort care. So I will briefly tell you just specifically about epilepsy, because that's my area of interest in neurology. So while epilepsy in 60 to 70% of the patients is just simply controlling the seizures, and it's done pretty easily with 1 or 2 drugs. But then you do have 25 to 30% patients where in addition to ongoing seizures, you have a lot of other things. It may be, an adult who had global developmental delay and has now is 40 years old, but is being taken care of by his parents. They may not have bladder bowel control. They may not be able to walk, varying disabilities. So these patients, of course, you will take care of their seizures, but all the rest remains unattended if you do not kind of, I think, integrate the concept of palliative care with your epilepsy care. So does that answer your question?
Yes, ma'am. Thank you. So absolutely. So patients who are having chronic limiting disease like stroke, epilepsy, or motor neuron disease. So we have a lot of such patients, and we do need to integrate their symptom management in addition to the disease control for a comprehensive care of these patients. Another important common disease in our setup, especially Delhi, a lot of pollution is there, and we see so many COPD patients in and around, and gradually they will progress, they will have a progressive disease. The common problem in these patients is they will have a lot of exacerbation, they will come to ICU, and many a times they will get settled, they will be cured, and they go back home. They will come again to the ICU after 3, 4, 6 months. So this cycle will continue. So it becomes a little difficult to ascertain that what is the day when we call it, yes, it is advanced and we need to initiate advanced care planning for these patients. Dr. Vijay is in pulmonary medicine at AIIMS. So sir, please enlighten us. How do you take care of these patients?
Good evening, everyone. So first of all, let me tell you, the COPD seems one of the common disease, and on the face of it, it seems it can be treated very easily, and that is true for most of the patient. And majority of patient, you will give bronchodilators and patient will feel happy. But it is everywhere it is written, it is an irreversible disease. There is no cure till date. So that we need to keep in mind. Having said that, there are good drugs now which can make patient very comfortable. Means his cough can come down, his dyspnea can improve, his quality of life can improve. But as the disease progresses, the FEV1 keep on falling, his lung function keep on deteriorating, then there will be time will come when his lungs are so poor that he will be able not to walk, even he can be so disabled that he is unable to take care of his day-to-day activities. And many times these patients will develop exacerbation of underlying disease, they lands up in ICU. So I think most important thing will be the stage of the disease. Once the disease is advanced, we measure FEV1, and based on that we can divide in mild, moderate and severe. So once patient is severe disease, those are the patients who are at the risk of development of exacerbation, as well as those who will require recurrent hospitalization or ICU care. So I think once patient is in maybe moderate or severe disease, we start thinking of palliative care. When patient first come to me, I usually don't think more regarding palliative care, because I know I have good drugs which can control most of his symptoms, and most of patient they will not require. But once you have optimized the treatment, and despite the treatment patient is symptomatic, his cough is not going down, his dyspnea is not settling, or he is repeatedly requiring hospitalization, in that case I think of Madam Sushma Bhatnagar, and many times I ask my resident that please consult them, and sometimes their residents are coming to our OPDs, so we consult them that what in addition we can do this patient. Yeah.
Thank you, Dr. Vijayada. So yes, that is important, and terminal dyspnea is also a common problem in COPD patients. Ma'am.
So I just want to add in this that it is always going to be difficult to integrate palliative care in non-malignant diseases. Because we all think that people are not going to die with non-malignant diseases, but this is not true. If a patient of COPD is requiring hospitalization, initially he used to come and follow up to Dr. Vijay once in a year. Then he is coming 6 months in a year. Then he is coming once in a month. And then he started coming once in fortnightly. And now he is coming every week. And he is getting hospitalized, and Dr. Vijay is sending the patient to treat the symptoms to ICU. पहले वो बोलेंगे relatives that ये ICU से निकल जाता था, अब क्या हो गया? So slowly the symptoms will increase and patient will require repeated hospitalization. So there are gold standard criteria of all these kind of diseases that we have to understand those that if a patient is requiring hospitalization, repeated, declining, is not able to do daily activity, I think he needs only symptom management, not the aggressive care.
Thank you, ma'am. Thank you.
One point I can add. All the respiratory disease, including COPD, actually dyspnea is one of the symptoms which is so fearsome that patient will be scared of that. No, I will not be able to take breath. So just imagine that कि आपको लगे कि मेरे को सांस आएगा ही नहीं. So that symptom is very, very scary, and once that is not controllable, I think palliative care can take care of that, because there are few drugs which can, if you prescribe them, then they will feel better.
Absolutely. So it is a kind of cycle. So if dyspnea will lead to anxiety, anxiety will lead to more dyspnea, and unless you break that cycle, it adds to the problem. So yes, we can give some simple drugs to reduce that. Now, a common symptom in most of the chronic disease and malignancy is pain. So most of the patients, when they are having advanced disease which is not curable, there is some amount of pain for whatever reason, and that pain needs to be addressed. So Dr. Rakesh, so what are the common drugs which can be used in advanced patients for management of the pain?
So majority of these patients will have pain in their journey of their life, whether it's malignant patients and non-malignant patients. And when we talk of cancer patients, especially the advanced disease, almost more than 90% of patients will have pain. And you must have always referred to something called WHO analgesic ladder. So it has empowered us to use the drugs depending upon the severity of pain. The pain-free is the right of each patient, and we have a lot of things in our armamentarium, and we can provide pain relief to majority of our patients at whatever the stage they have. We have something to give to them even in the advanced disease. If we see the armamentarium of the drugs that we have, depending upon the assessment of these patients, we can use analgesics like starting from paracetamol and NSAIDs, and then we can move on further with step 2, which is tramadol. And majority of these patients, especially when they are advanced disease, will be requiring strong opiates like morphine. Also, we have the pain, usually this will be something like a mixed type of pain. Mixed type of pain, I mean the tumor will be involving some nerves, some tissues, some bones. So usually we use combination of drugs for these patients, and depending upon our assessment, we can add on drugs like anticonvulsants, which are gabapentin or pregabalin, antidepressants, amitriptyline drugs we can add on, along with drugs like paracetamol, which is quite safe. And as Professor Sushma Bhatnagar mentioned that using morphine, which is a wonder drug for these patients, we just have to learn some basics from this, and the certificate course she was talking about, this empowers us to use it quite safely in these patients, and these are required. We should not be afraid of not giving these drugs to the patient. We think that it has a potential of addiction, or it has a potential of misuse. But if we use it appropriately under supervision, we keep all our patients follow up. Using this drug gives pain relief to majority of patients. And as we were discussing in Dr. Bhatnagar's slide also, the presence of pain is one of the very debilitating situation for the patient, not only for patient but the caregivers also. So please do not divide off your patients of whatever, whether malignancy and even non-malignant patients. Madam was talking about the neurological symptoms, patients of paraplegic trauma patients, patients with liver failure, patients with kidney failure, patients with heart failure. They also have almost to the tune of 40 to 60% manifesting as pain. And this step ladder pattern will allow us to provide good pain relief to these patients, and we are doing it. And I'm sure each one of you if you just basically understand how to provide it, I think all of you can provide good pain relief to all the patients.
Thank you, Rakesh. So, in addition to drugs, Dr. Vinod, do we have any interventions that we can do, especially in patients with advanced malignancy, to reduce the symptom burden?
Yeah. As we know, providing drugs is not the only solution, because the drugs will have some side effects, especially stronger opioids like morphine or fentanyl. These patients will be having constipation, nausea, vomiting, and in some patients, some of the patients might have respiratory depression, but not in all patients. So providing intervention will definitely help them. And some of the interventions, like in fact in WHO ladder, the step 4 has been included as a step 4 as an intervention analgesic, and this can be intervention can be done on any step. You don't have to go from step 1, step 2 and 3 followed by step 4. If the patient present with some feasible block, which can be like head and neck block, or there are various block like the splanchnic plexus block, celiac plexus block, or superior hypogastric plexus block for various malignancies. So you can provide, and these are most of the blocks can be provided on bedside with the help of ultrasound, and quite easy without any radiation exposure, and the effect lasts depending on if we are giving diagnostic or therapeutic. The therapeutic is usually we give alcohol, absolute alcohol with the mixture of 0.25% bupivacaine, and that effect will last for at least 3 to 6 months. So the patient will be requiring lesser of stronger opioids. So in that way we can reduce the requirement of stronger analgesic, thereby improving the quality of life. Other intervention these patients, the cancer patients may present with, like if the patient is having head and neck cancer, so there may be trismus, patient is not able to eat anything. So we can provide, we can insert simple nasogastric tube to provide nutrition. Then the patient may be having effusion. If the patient is having lung cancer or any malignancy related or lung metastasis, patient may be having pleural effusion coming with dyspnea. So simple pigtail catheter insertion and followed by pleurodesis. So the patient will not have multiple, he don't have to come multiple times in the OPD just for pleural thoracentesis only. So that will be definitely improving the quality of life, reduces the number of visits to the hospital. Similarly, ascitic tapping, that is there in most of the patients who are suffering from carcinoma ovary. So these patients will be coming week by week for with dyspnea due to huge amount of ascites. So ascitic tapping is quite a common procedure which can be done to reduce, to improve the quality of life, to reduce the dyspnea. So these are some of the interventions which can be done. So in these patients.
Thank you, Vinod. So now we have been discussing that there is a time when the disease it becomes very advanced and it is futile to escalate the therapy. So Dr. Sachidanand, can you tell us when do we know actually it is futile, and what should be the cutoff that we decide for futility of care and starting the palliative care for these patients?
During course of any chronic illness, whether it is advanced malignancy or non-malignant chronic diseases, a stage comes when the curative treatment is not effective, and this if you provide curative treatment to these patients, this adds burden to the only medicine burden and the cost burden. So at that point the physician, the primary physician has to take a call, and they have to introduce the concept of futile exercise or futile medicine or futile treatment to the patient and their relatives, and they have to make them understand that okay, we are not going to provide any curative treatment, but yes, we will provide the medications and support for the symptoms, so that your life will be comfortable and will not abandon you to die in agony or pain or with burden. So this concept has to be introduced by the primary physician, and it takes time, it takes multiple sessions, because patients keep on coming and they ask, doctor sahab kuch to kar sakte hain. So in this scenario you can also ask them to go for a second opinion if they want.
Thank you, Dr. Sachidanand. So absolutely, so there are always it is a difficult question to decide futility, but yes, there are different guidelines and frameworks in place, like a GSF prognosticating indicator guidance, as ma'am was suggesting. So it is a complete class in itself, but yes, we must be aware that there are things in place and we can follow them, and medico-legally also we are on the safe platform to decide futility of care for these patients. Now, for most of the patients having an advanced disease, you often need opioids for different symptoms like pain, dyspnea, and other symptoms. And morphine and other opioids are much needed in these patients. The problem is that how many people...
Hello, I just want to request you, if you want, we can stop. But please don't make noise. It is so disturbing. Imagine so many people have come on Sunday just to tell you something new and you are talking. If you really don't want, we can stop. But don't make noise. Everybody is talking to each other. What is this? Somebody is taking selfie, somebody is talking. This is not right. This is, you are not respecting people, those who are coming all the way to teach you something new. No, it is not like this.
So, opioid procurement and dispensing is always a challenge. How many in the hall actually have opioids at their setup for use in patients, such patients? So, a very few, yes, limited people have it. So, there is a challenge to procurement. So, we'll have some insights into from opioid procurement and dispensing from Dr. Brijesh.
Thank you, sir. Very good evening to all. Procurement of opioids is now, after amendment of 2014 in NDPS Act, it's now become easy and it's safe, and even any person who is registered under Medical Council of India or Dental Council of India and who is interested in palliative medicine can procure opioids through following a small channels and rules, and all these rules are amended in 2014, and after this amendment there is only one single authority for procurement and stocking of opioids, which is a State Drug Controller or Commissioner, and any medical practitioner can apply to State Drug Commissioner with there's different forms. I am not going in details about all these forms. There is form 3F for the approval, then form 3C for consignment. All these forms are available in Government of India's site, and all forms are very clear, and the government and NDPS Act only wants to procure all opioids in this pre-prescribed proformas, and all proformas should be kept for another 2 years, and annually it should be informed to State Drug Commissioner regarding the uses, and another form 3J should also be submitted for the estimated annual consumption of coming years, and it's all are very simple, and a slight approach can be used to procure the opioids. Basic things are that there should be a dedicated space for the storage of opioids which have a double lock key facility. This storage should be mentioned and informed to State Drug Commissioner and a dedicated pharmacist who kept the records, and all records should be maintained on daily basis in form 3H, and whenever we prescribe these medications to patient, another form that is form 3E should fill in capital letters, and the prescriber or doctor should write his or her full name in capitals with registration number.
Thank you, Brijesh. So there are set guidelines which need to be followed, and if we do it diligently, believe me, it is not difficult, and it makes life easy for us and for the patients as well. Before I come to the last question, now we have Dr. Chugh also with us on the stage. Ma'am, what is your experience with handling patients with advanced disease in your setup, and how do you actually manage them, and how do you initiate palliative care in these patients?
In the corporate sector, actually that is the problem. In the corporate sector, they have treatments for oncology and everything, But then when it comes to palliative care, they keep on prolonging the oncology treatment. The medical oncologist, the surgical oncologist will just keep on prolonging, not realizing that the beds in the ICU are getting filled. To some extent, it may be that it is in their interest that the ICU beds are full, but to the patient's point of view, if you were to see that the burden of economic burden that is coming on to them is very, very immense. So you have to start thinking from the patient's point of view and the relatives' point of view who are bearing the burden of the ICU bed. So that is where you have to actually enlighten the private hospitals that there has to be a limit. Stop, this is enough, and talk to the patient's relatives, enlighten them that this is where we will have to draw a line. And now if you still want, okay, we have a ward where we can shift these patients and they'll be taken care of in a gentle way and in a dignified way, they'll pass out. So that has to be explained. But first, the oncologist, the surgical oncologist, the medical oncologist must know where to draw the line. So the training has to be at their level. This is what I feel. I'm not an oncologist, but this is what I feel, that this is how it has to be. You must understand, because all of us sitting here think we are never going to have malignancies, we are never going to need this. But believe me, the way India is moving, we will all need it, or we, God forbid, but we or some relative will need it. And then when it comes to our own relative, when we have to take a call, we are at a loss, because our colleagues in the medical oncology will say no, prolong life, the surgical will say prolong life, and then nobody is able to take that call. So that is where I'm saying each one of us should listen carefully, because it's not going to be, it could be endometriosis. I'm a gynecologist. Endometriosis is debilitating. Cancer is debilitating. But unless you understand how badly that patient is affected, you will never be able to go put yourself in the patient's foot. Ask somebody who is suffering from chronic diseases, put yourself in that patient's place, see where the economic cost is going, then you will realize that how you have to include palliative care in your everyday treatment. That is what each one of us is believing. No, nothing can go wrong with us. We can dance, we can do everything. No, there will be a stage when each one of us will need all this. So do that. Start thinking seriously. You or your parents or somebody in the family needs it, but we are not willing to discuss it only. They are trying to teach us, but we are not willing to accept it. So start teaching. Start teaching your juniors, start teaching your seniors, that be careful towards, think of yourself in that place and then talk. That's it. Thank you.
Thank you, ma'am. Thank you. So, ma'am, the final question, Dr. Sushma, for you now. Now, this is a challenge of end of life care. We have to counsel the patients. But as doctors, we are afraid medical legal issues might be cropping up. And how do we safeguard our students, our colleagues, when they are introducing end of life care for the patients?
Okay, so first I will start with this, that in our country, everyone is dying in agony. I told you, poor is dying in agony because they are not getting beds and ICU beds. Middle class is dying in agony by selling off their land and the house and putting their patient in ICU. And even the filthy rich people are dying in agony away from their loved ones. Their hands are tied and their tubes are in and on ventilators. Now, Nishkarsh has asked me about the legal. See, I don't understand. When we know the treatment, when we know how to diagnose, this is part of our medical teaching. When we know that this is the way we are going to treat, this is part of our medical teaching. For example, COPD. COPD patient, we are teaching, it's good. There are good bronchodilators and there are good medication. The patient can be treated very well. And we should treat that patient definitely. We should keep treating this patient till the time, if patient is started coming twice in a week to your hospital and you are all the time your patient is requiring ICU bed, and even if he is going back from ICU to home, he is always on oxygen. There is an oxygen cylinder with the patient, and patient is always on bronchodilator. He just cannot get up from the bed and he just cannot go to the toilet. What is the quality of life we are providing to the patient? Why can't we explain to the patient and talk to the patient and give the honest information and write down, document on the papers, whichever paper you are using in your hospital, that will become a legal document. This is a medical, that's why the country who are having the best quality of life, this is a practice. If a patient who is requiring all the time oxygen, he is unable to breathe, a patient with a carcinoma breast with lung, brain and liver mets and with bony mets, they don't put this patient on ventilator, they don't put this patient in ICU. They will explain to the patient, they give the information what is the disease status, they will explain to the relatives, they will explain to everyone, they will write down. This is practice, this is what we are practicing. We go and do the family meetings and we write down that we have discussed the disease prognosis, we prognosticated, we have explained the disease status, we have given the probable. This is what, if you will have a, you will start having a frequent family meetings with the patients and the relatives, then this problem will not come. This is not a legal this thing. You write down that I have spoken to the mother, father, wife, husband and explained the disease status, and if I will, this is the various choices of the disease. Patient will make the choice of their own. They will say, most of the time, you know, in these days in IRCH we have 100%, we don't put any patient on ventilator who is going to die. Patient themselves understand. They say that if I am not going to be cured, just give me pain management and I want to go home. So this is the way we have to work. Where is the legal this thing? There is no legal. And if at all you are legally worried, there is an end of life care policy of AIMS, you can this thing. ICMR has given enough document, DNR document was there, and they have given a very good flow chart. If a patient is suffering with any chronic debilitating condition, this is the way you have to approach to the patient. So this is the approach, and there is no legal entity. You know, legal things will happen when you will not communicate to the person. You know, all over world, when I was giving this lecture, when legal aspect only, I have searched enough literature, and wherever I have found that there were any legal suit happened or patient went or relatives went into the court, they just went to the court because they were not told properly. So communication is the key of success. You start teaching to your juniors, you start teaching yourself, take one patient at a time. And I am telling you today, we have given, you have given your time, we have given our time. We have spent 2 hours, and what I will request you, that if you will start communicating one patient in a month properly, you will have a habit of explaining one patient in 15 days, and then you will start explaining to one patient in a week if they are genuinely dying. You please rule out all the reversible causes, and once you have ruled out all the reversible causes and you know that this patient is not going to survive, you please start end of life care program to this patient. And you know, end of life care program is not going to be beneficial for patient only. Patient and relatives, they will feel happy. All our patients, those whom we are giving end of life care policy program, they are coming and thanking that my patient died with dignified. But this is beneficial for the staff also. The nurses, those who are looking after your terminally sick patient in ICU, they are also very distressed because they know that every day this patient's relatives are paying 40,000, 50,000 in private hospital, or they are away from loved one, a mother who is away from her children. I think what we are doing, so they are distressed. So staff will be very satisfied, you yourself will be satisfied, and finally your organization, because ultimately in corporate hospital we have to explain to the administrators. So the organization will also be benefited because the beds which you are using unnecessary for the patient, those who are not going to be survived, or those who are going, we are giving them suffering. And you know, 2014 end of life care verdict, Supreme Court verdict clearly says, if you are at all worried about only legal aspect, that you have to work in the best interest of the patient. And best interest of the patient, you are going to decide. If best interest of the patient, you think that putting patient in ICU is best interest, put the patient in ICU. But if you think that it is not in the best interest of the patient, don't put that patient in ICU. Give them symptom. Don't desert your patient, because if you will desert your patient, patient will go into the court. How will the patient will be satisfied? By giving good symptom management, by empowering family member that this is the way you are going to take care of your patient at home, and by providing them some kind of a support system that if at all you need, please call this number or come here, but don't go to the hospital frequently if this patient, this is the way you can treat this patient. And every patient every person wants to die at home. If I ask in the hall that where do you want to die? Where do you want to die? How many of you want to die in the hospital? How many of you want to die in ICU with your hand tied? But you know, if you will not develop a system, everybody will put you in ICU because you are the senior most doctor of Delhi government. So you have to create a system. Everybody wants to die at home? Raise your hands. How many people wants to die at home? Everybody wants.
Let's on a lighter note.
So this is a difficult question that nobody wants to die, but if death is inevitable. So I'll talk about, in just 2 minutes I will talk about euthanasia also. So death is inevitable. If sometime, if at all it will come, everyone wants to die at home with loved one. So we have to create this kind of a system, and if we will not integrate this concept, how will we create this system? So about euthanasia, Dr. Bhalla has asked me to talk. Euthanasia is voluntary giving some medication to the patient and hastening death. Palliative care is not euthanasia. Palliative care allows patient to die dignified way, in a dignified way, till palliative care allowed patient to die naturally. We are not going to hasten death by giving propofol or by muscle relaxant or something, but we are not going to postpone death by putting this patient in ICU and by giving vasopressor. We will allow patient to die naturally till the patient is alive. We are not going to desert this patient, and we will be with the patient, and we will provide comfort care and symptom management. Thank you very much.
Thank you, ma'am. Before we end, I thank my senior members, the faculty from AIMS, the various heads of the departments for coming here on spending some time on Sunday and enlightening you all regarding the palliative medicine. Thank you very much for organizing this.
Sir, sir, we are running short of time. You can ask the question personally now. I'm so sorry I am intervening in between, but we have to respect the time also. It was really, really wonderful and enlightening talk, and it was really thought-provoking. At least it has given us a thought that we will think about it once again, and will definitely follow it. Thank you, Sushma, and we are really grateful to the whole team which has taken out time for us and giving us a new direction in the medical field. A good round of applause to everyone. And Dr. Nishkarsh, you are a good moderator too. Now I will invite Dr. Tyagi to please come on the stage, and Dr. Dalmia, our DMA president, to come on the stage to deliver the memento to the guest. Please. Sushma, you please join the group to hand over the memento. Bilkul. Dr. Nishkarsh Gupta. Dr. Nishkarsh. Really a wonderful job, Nishkarsh. अच्छा निष्कर्ष निकाला इन्होंने आज. डॉक्टर लाइट्स ऑन कर दीजिए प्लीज. लाइट्स बोलो ऑन करने के लिए. लाइट्स ऑन करना प्लीज. यस सॉरी. डॉक्टर एस देव. ओके. डॉक्टर अतुल शर्मा. Dr. Seema Mishra. Dr. Seema Mishra is there. Dr. Seema Mishra. Dr. Praveen Agrawal. Dr. Mamta. Dr. Praveen Agrawal. Achha, sorry. Dr. Praveen, Dr. Praveen Agrawal. Dr. Mamta, please. Dr. Rakesh Garg. Sorry. Rakesh Garg. Dr. Rakesh Garg. डॉक्टर विनोद कुमार. बिल्कुल ये बहुत गलत बात है. आप लोग क्या पैलिएटिव में इतने गुम हो गए कि घबरा गए हैं? मृत्यु तो आनी है. अभी तो ताली बजाएं. डॉक्टर सच्चिदानंद जी. हम उनको ना नकली दे देते हैं, दोबारा नाम बना के दे देंगे. डॉक्टर विजय हड्डा. ओके. Dr. Vijay Hadda and Dr. Surinder Saini. We'll give the name later on. Vijay Hadda. कितने बच गए? सुरेंद्र सैनी और फिर अच्छा. Dr. Surinder Saini. हाँ हम बना के भिजवा देंगे. नहीं हम बना के भिजवा. And Dr. Brajesh. Dr. Brajesh का तो है. Dr. Brajesh. We'll change the names if there is some confusion. Sorry. Dr. Brajesh. Continuous clapping होनी चाहिए अब. It is such a wonderful talk. And we all enjoyed the every moment of this talk. And first time I have seen the hall to full extent. Good.
We'll have a group photo.
Keep on organizing.
All delegates to please take their seats. If we could have silence in the hall, we could proceed with the inaugural and awards function. Good evening, friends, delegates, awardees, ladies and gentlemen. My name is Dr. Sanjeev Malik, and I've been assigned the pleasant task of conducting the inaugural and awards function for today evening. Being dot on time and wanting to end dot on time because you have a cultural program which has to follow, may I request our most energetic, dynamic President DMA, Dr. Ashwini Dalmia, to please escort our chief guest for today, the National President IMA, Dr. Shahjahan Prasad Singh. May I request Dr. Prashant Seth, the officiating State Secretary, Dr. Avtar is not well, to please escort our guest of honor, Dr. Arun Gupta, President, Delhi Medical Council. May I now request Dr. A.S. Popely and Dr. Satish Tyagi to please escort Dr. Girish Tyagi, Secretary, Delhi Medical Council, to the dais. Could I request friends on the left hand side to please take your seats? A quick introduction of colleagues and dignitaries on the dais. I start from my extreme left, that's your extreme right. Dr. A.S. Popely, Honorary Finance Secretary of Delhi Medical Association. Dr. Prashant Seth, Officiating State Secretary, Delhi Medical Association. Dr. Arun Gupta, President, Delhi Medical Council. Dr. Shahjanand Prasad Singh, National President of the Indian Medical Association. Dr. Ashwini Dalmia, President, DMA. And Dr. Girish Tyagi, Secretary, Delhi Medical Council. I would now request our President, State President, Dr. Ashwini Dalmia, to please present a floral bouquet and welcome our chief guest of today, the National President, Dr. S.N.P. Singh. That's from Dr. Ramesh Datta. I'll now request Dr. Prashant Seth to please present a floral bouquet to our guest of honor, Dr. Arun Gupta, President, Delhi Medical Council. Dr. A.S. Popely, Finance Secretary, DMA, to please present a floral bouquet to our guest of honor, Dr. Girish Tyagi, Secretary, Delhi Medical Council. I'll now request Dr. Ashwini Dalmia, President, DMA, to deliver his formal welcome address. Dr. Ashwini Dalmia, please.
गुड इवनिंग, नमस्कार, आप सभी का हार्दिक अभिनंदन। माननीय नेशनल प्रेसिडेंट डॉक्टर सहजानंद प्रसाद जी, चीफ गेस्ट ऑफ द डे, डॉक्टर अरुण गुप्ता, प्रेसिडेंट दिल्ली मेडिकल काउंसिल, डॉक्टर गिरीश त्यागी, रजिस्ट्रार दिल्ली मेडिकल काउंसिल, पास्ट प्रेसिडेंट दिल्ली मेडिकल एसोसिएशन, my colleagues, officiating secretary Dr. Prashant Seth, finance secretary Sahab Dr. A.S. Popely, and my dear friend, elder brother Dr. Sanjeev Malik, जिनको आज हमने गुजारिश करके अवतार किशन जिनकी एब्सेंस में मास्टर ऑफ सेरेमनी, थैंक यू वेरी मच। डॉक्टर संजीव मलिक इज़ पास्ट नेशनल प्रेसिडेंट ऑफ इंडियन मेडिकल एसोसिएशन। दोस्तों, हमारे कार्यकाल के 3 महीने 24 दिनों में ये महिलाओं पर केंद्रित, महिला डॉक्टरों पर केंद्रित हमारी तीसरी इवेंट है। तो मुझे मुझे नीचे किसी ने पूछा कि महिलाओं पर बार बार तीसरी इवेंट का कोई लॉजिक नहीं है। तो मेरा उस सज्जन को, बैठे हुए हैं, नाम लेना वाजिब नहीं होगा, वोट कट जाएंगे उनकी महिलाओं से। महिलाओं की एसोसिएशन में इन्वॉल्वमेंट बहुत ज़रूरी है। महिलाओं की हर क्षेत्र में इन्वॉल्वमेंट बहुत ज़रूरी है। महिलाओं से सौम्यता आती है, महिलाओं से शिष्टाचार आता है। इससे पहले भी हॉल कई बार भरे हैं, लेकिन इस तरह से खूबसूरत अलग अलग रंग बिखेरती हुई फ़िज़ाएँ, हवाओं वाली खूबसूरती दिल्ली मेडिकल एसोसिएशन में कभी देखने को नहीं। और मैं अपनी सभी माताओं बहनों का अभिनंदन करता हूँ, एक्सेप्ट माई ओन वाइफ सुलेखा जी। दिल्ली मेडिकल एसोसिएशन DMA बिकम डेली मेंस डॉक्टर एसोसिएशन। ये DMA विजुलाइज कीजिए आप DMA को, ये M को उल्टा कर दीजिए आप, मेक इट डेली वीमेन डॉक्टर्स एसोसिएशन। आपकी सक्रिय राजनीतिक भागीदारी बहुत ज़रूरी है। इसीलिए मैं आपको अश्योर करता हूं कि 3 नहीं 12 इवेंट होंगी हमारी इस पूरे साल में जो महिलाओं पर केंद्रित होगी। मैं 2008 से 11 में स्टेट सेक्रेटरी था। उस समय ये जो नल्ली साड़ी वाला कॉन्सेप्ट मैं कॉन्फ्रेंस में लेके आया, बड़े सारे मेरे दोस्त बैठे हैं जिन्होंने प्रेस में और इधर उधर मेरे खिलाफ छपवाया कि इलेक्शन लड़ने के लिए नल्ली साड़ी बांटी जाती हैं। अब तो मुझे कोई इलेक्शन भी नहीं लड़ना, पर मुझे लगता है कि क्यों महिलाओं को इंसेंटिव क्यों नहीं मिलना चाहिए। एक डॉक्टर होने के बाद भी महिला अपने घर में गृहिणी की पूरी जिम्मेदारी निभाती है। आज भी आप में से बहुत सारी महिलाएं फ़ोन पर कोऑर्डिनेट कर रही होंगी, बेटे पढ़ाई कर ले, दूध पी लिया, खाना खा लिया, दिस दैट ब्ला ब्ला ब्ला। दिल्ली मेडिकल एसोसिएशन कमिटेड है, बहुत ही विनम्रता से कमिटेड है आप सभी के हक, आप सबकी भागीदारी को जोड़ने के लिए। दूसरी बात जो बार बार सर कही जाती है कि अवार्ड इतने सारे क्यों बांटे जाते हैं। हम लोग 17,500 डॉक्टर्स हैं दिल्ली में। दिल्ली मेडिकल एसोसिएशन की ऑफिशियल स्ट्रेंथ 17,500 है, जिसका 1% है 175, आधा % हुआ, मेरा मैथ बहुत कमज़ोर है, 35 और 50 85। आज के अवार्ड बहुत ज़्यादा नहीं है, 60 हैं। हर डॉक्टर जो अपने पूरे करियर में रात के 12 बजे किसी मरीज़ को देखने के लिए उठा है, जिसने अपनी परिवार, अपने बच्चों की शांति में, तरक्की में खलल डाल के अपने प्रोफेशनल जिम्मेदारी को निभाया है, वो डॉक्टर एसोसिएशन से सम्मान पाने का हकदार है। हम 60 नहीं, हमारा बस चलेगा तो हम 17,500 लोगों को अवार्ड दें। और सुलेखा बता रही थी कि यार नल्ली साड़ी वाला कॉन्सेप्ट काफ़ी पुराना हो गया, तनिष्क पे आओ। आप अगर इसी तरह से साथ देते रहे तो मैं आपको अश्योर करता हूं बहुत जल्दी हम तनिष्क पर आ जाए। क्यों मेरी बीवी से पिटवाना चाह रहे हो सर? सहजानंद सर से पूछें परिवार में क्या क्या सुनने को मिलता है प्रेसिडेंट बनने के बाद। तो मेरे ख्याल से जितना बननी है उसके लिए आपका हार्दिक धन्यवाद। एक बात मैं और कहना चाहूँगा, काउंसिल के एग्जेक्टिव मेंबर के नाते बहुत सारे इश्यूज़ हैं, देखने को मिलते हैं। आई एम श्योर हमारे बड़े भाई डॉक्टर अरुण गुप्ता जी और डॉक्टर त्यागी दोनों हैं, वो इस मुद्दे को टच करेंगे, तो मैं छोड़ रहा हूँ उनके लिए। आज नेशनल प्रेसिडेंट हमारे बीच हैं। आप में से कम लोग राजनीतिक हो, पॉलिटिकली, मेडिकली आप लोग कम पॉलिटिकली एक्टिव हो। हमारा चुनाव, इंडियन मेडिकल एसोसिएशन का चुनाव सर पर है। 31 जुलाई को लास्ट डेट ऑफ नॉमिनेशन है, अगर मैं गलत नहीं हूँ। दत्ता साहब आप तो सबसे बड़े एस्पिरेंट हो। 1 तारीख। सर मेरी आपसे विनम्र प्रार्थना है, मैंने डॉक्टर्स डे पे भी आपसे प्रार्थना की थी। पिछले 90 सालों से इंडियन मेडिकल एसोसिएशन के सेक्रेटरी जनरल दिल्ली से होते आए हैं। पिछली 2 बार से ये परिपाटी टूटी है। मैं, आप पुरुषों की तो नहीं सुनते, मैं इन तमाम महिलाओं के बिहाफ पर और पूरी दिल्ली मेडिकल एसोसिएशन के बिहाफ पर आपसे प्रार्थना करूंगा कि दिल्ली मेडिकल एसोसिएशन को उसका जायज़ हक सेक्रेटेरिएट वापस मिले। आप इंश्योर कीजिए कि सिलेक्शन में दिल्ली मेडिकल एसोसिएशन, दिल्ली के डॉक्टर ही IMA हेडक्वार्टर के सेक्रेटेरिएट को चलाएं, क्योंकि बाहर से सेक्रेटरी लाने का फार्मूला वो पिछले 4 सालों से सक्सेस हो नहीं पाया। इसके लिए मैं विशेष रूप से जिसके लिए जाना जाता हूँ, वो 4 पंक्तियों में आपको दिल्ली के डॉक्टरों का दर्द बताना चाहूँगा कि लकीरें खींचो, मिटाओ, तुम्हें इजाज़त है। ये तुम्हें वर्ड काफिया के लिए इस्तेमाल किया गया, वैसे आदरणीय आप लकीरें खींचो मिटाओ तुम्हें इजाज़त है, हमारे दिल को दुखाओ तुम्हें इजाज़त है। गए दिनों में समंदर जहाँ पे होता था, समंदर मैं कह रहा हूँ पिछले 90 साल के सेक्रेटेरिएट को, जिन्होंने अपनी जान दी है। हमारे डॉक्टर संजीव मलिक साहब सेक्रेटरी जनरल रहे हैं, डॉक्टर विनय अग्रवाल साहब बैठे हैं सेक्रेटरी जनरल रहे हैं। आई कैन नॉट सी दी फेसेस ऑफ डॉक्टर नरेंद्र सैनी एंड डॉक्टर DR राय, बाकी सारे दोस्त, लेकिन सब लोगों ने कितना खोया है वहाँ पर सेक्रेटरी जनरल बनने के लिए, कितना त्याग किया है, इसको आप ज़रूर इस लाइनों में गौर फरमाइएगा कि गए दिनों में समंदर जहाँ पे होता था वहाँ पे रेत बिछाओ तुम्हें इजाज़त है, और तुम्हारे नाम है महफिल, तुम्हारे शाम नाम है, दिए जलाओ बुझाओ तुम्हें इजाज़त है। थैंक यू सर, थैंक यू वेरी मच, एंड थैंक यू ऑल ऑफ यू फॉर बीइंग हियर। थैंक यू सर।
Thank you, Dr. Dalmia. May I now request all dignitaries on the dais, led by our national president, to please light the inaugural lamp. ऐसा करते हैं, इनके एड्रेस के बाद ही करते हैं।
मंगलम मंगलम गणेशम मंगलम 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 गणेशम मंगलम मंगलम
गणपति देवा
देवा गणपति देवा मंगलम गणेशम। देवा हो देवा गणपति देवा मंगलम गणेशम। देवा हो देवा गणपति देवा मंगलम गणेशम। देवा हो देवा गणपति देवा मंगलम गणेशम। विघ्न विनाशक जन सुखदायक, विघ्न विनाशक जन सुखदायक मंगल।
Thank you, friends. I would now request Dr. Arun Gupta, President, Delhi Medical Council, and the guest of honor for today, to please deliver an address, a brief one, please, because we have a lot of awardees waiting and the cultural program to follow. Dr. Arun Gupta, please.
Good evening, everyone. All the dignitaries on the dais and the ladies and gentlemen. अश्विनी डालमिया को हमसे शिकायत हमेशा रहती है कि पहले मेरी स्पीच आती थी तो नहीं था कि सारे मेरे कंटेंट तो पहले ही बोल देता था, बाद में मैं क्या बोलूँगा। आज जान के उल्टा किया है इसने। तो एनीवे, आई विश ऑल द women of Delhi Medical Association a wonderful evening, and we look forward to your performances. And as a president of Delhi Medical Council, I would say we are having a very, very tough time. Honestly speaking, मैं आपको थोड़ा सा हार्ड हिटिंग फैक्ट्स बताना चाहता हूँ कि अपॉर्चुनिटी आज हॉल पूरा भरा है। आप में बहुत से लोग हैं जो शायद पहली या दूसरी बार आए, हर बार नहीं आते, बट यू मस्ट नो कि क्या चल रहा है। नंबर ऑफ केसेस अगेंस्ट डॉक्टर्स आर इंक्रीजिंग एक्सपोनेंशियली। थोड़ा सीरियस मामला है, और पहले हम लोग दिल्ली मेडिकल काउंसिल में शायद महीने में 1 या 2 एग्जीक्यूटिव मीटिंग करते थे, अब हमें 3 या 4 बार करनी पड़ रही हैं, मतलब केसेस बढ़ रहे हैं। तो थोड़ा सा आप लोग ध्यान रखें। कुछ बातें मैं बताना चाहूँगा कि क्या हो रहा है आजकल। पीपल बिकम वेरी वेरी you can say they're right oriented, I would say, and there are people who are instigating them, there are people who are supporting them, maybe they are doctors, maybe they are lawyers, maybe they are politicians, maybe they are police वाला, maybe they are पड़ोसीज। नंबर ऑफ केसेस बढ़ रहे हैं। तो हमने कुछ चीज़ें देखी हैं, मैंने जो कुछ दिनों में ऑब्जर्व किया है। there are certain things which you do intentionally wrong, and there are certain things which are done unintentionally. Now, as a professional, we all are very, very good. And whenever we judge a case, we always peer review. इट मान लो किसी ऑब्स्टेटिशियन का केस है तो हम आपके में से ही बीच में किसी ऑब्स वाले को बैठा देते हैं. हम बोलते हैं मैडम आप देख लो इसको, अंडर द सेम सर्कमस्टेंसेस व्हाट वुड हैव यू डन. उसमें से अगर कोई ग्रॉसली बहुत गड़बड़ नहीं किया है तो हम लोग एज ए काउंसिल कहते हैं जाने दो. देयर हैज टू बी समथिंग वेरी वेरी ग्रॉस डेविएशन फ्रॉम द एक्सपेक्टेड नॉर्म. But there are certain things which are intentionally wrong that are not acceptable to us at all. Number one, never flaunt a degree we do not possess. बड़े केसेस आ रहे हैं, आप ऐसे डिग्री लिख देते हैं, अब वो आपकी डिग्री है ही नहीं. अगर आप MBBS है तो MBBS लिखिए, प्लीज़ MD मत लिखिए. अगर आप कार्डियोलॉजिस्ट नहीं है तो कार्डियोलॉजिस्ट मत लिखिए. चलता रहता है, पर जिस दिन केस फंसता है सबसे पहले कंप्लेंट ये आपकी डिग्री चेक करवाता है. और आपकी डिग्री अगर मिल गई जो कि MCI रिकॉग्नाइज नहीं है तो आपने केस वहीं हार गए, फिर आप बच नहीं सकते. नंबर 2, रिसेंटली देखने में आ रहा है कि मेडिकल सर्टिफिकेट्स बहुत बना देते हैं हम लोग. कभी भी किसी पड़ोसी के लिए, रिश्तेदार के लिए कभी भी कहने पे मेडिकल सर्टिफिकेट फॉल्स नहीं बनाइए. फरवरी के महीने में 2 डॉक्टर्स का नाम रजिस्ट्रेशन कैंसिल किया गया इसीलिए कि उसने फॉल्स मेडिकल सर्टिफिकेट बनाए थे. होता है कि सामने वाला कंप्लेनेंट होता है, कोई ना कोई पार्टी आगे कंप्लेंट कर दिया, आप जो चीज़ डॉक्यूमेंटेड है उसको आप डिस्प्रूव कर ही नहीं सकते. पेशेंट जेल में बैठा है तिहाड़ में और आपने बाहर सर्टिफिकेट बना दिया उसका, तो अरुण गुप्ता कैसे बचाएगा और त्यागी कैसे बचाएगा आपको. इंटेंशनली गलत मत कीजिए. तीसरा भी केस देखने में आ रहे हैं, इंश्योरेंस के चक्कर में गलत काम होने शुरू हो गए. सर्जरी करी कुछ है, डॉक्यूमेंट कुछ किया है, डिस्चार्ज कुछ बनाया, और बिकॉज ये सर्जरी के पैसे ज़्यादा मिलते थे इंश्योरेंस कंपनी से. जिस दिन फंसेंगे बहुत बुरा फंसेंगे. तो इंटेंटली गलत करेंगे तो हम भी आपको सपोर्ट नहीं करेंगे, मैं साफ बता रहा हूँ. पर आप प्रोफेशनल कैपेसिटी में अगर आप अच्छे से काम करते हैं और कुछ भी गड़बड़ होता है तो काउंसिल आपके साथ में है. हम आपको गलत फंसने बिल्कुल नहीं देंगे जहाँ एज फार एज योर प्रोफेशनल कंडक्ट इज कंसर्न. बट इंटेंटली गलत बिल्कुल मत करिए. हमें काफ़ी तकलीफ इस बात की कि हमारे दोस्त लोग ऐसा करते हैं, देन वी आर रियली स्टक कि करें क्या. और दिल्ली मेडिकल काउंसिल में सारी चीज़ अच्छी हो गई, नई बिल्डिंग बन गई, आप लोगों को बता चुका हूँ मैं कई बार. यू आर मोस्ट वेलकम टू कम एनी डे. और सारा काम ऑनलाइन है, रजिस्ट्रेशन, री रजिस्ट्रेशन, एंड वी हैव ए हेल्पलाइन ऑल्सो. अगर आपको दिक्कत आप कॉल करके, हमारे बंदे हेल्प करते हैं. और डॉक्टर डालमिया बैठे हैं, मैं DMA के जो भी उनसे बोलना चाहता हूँ कि दिल्ली मेडिकल काउंसिल, मेरे को लग रहा है सीरियसली हमें आपको टीच भी करना चाहिए. अब ये मौके तो कभी कभार आते हैं, तो DMA के जितने भी ब्रांचेस हैं आपके 13, आप 13 की 13 जगह मेडिको लीगल इश्यूज से 2-3 घंटे के हाफ डे का सेमिनार कराइए. रिसोर्स पर्सन हम देने को तैयार है, हम स्पॉन्सर भी कर देंगे दिल्ली मेडिकल काउंसिल पर. हमारा ये काम है आपको टीच करना. तो सारे ब्रांचेस में कर लीजिए. और आपके जो लेडीज़ बैठे हैं, आपकी ऑप्स एंड गायनी है, सबसे केस आते हैं, या जो आपकी अलग स्पेशलिटीज़ हैं उससे रिलेटेड भी कर लीजिए. दिल्ली मेडिकल काउंसिल आपको रिसोर्सेज भी देगी. हमारा बहुत अच्छा ऑडिटोरियम है, आप वहाँ भी आएँ, यहाँ भी करें, अपनी ब्रांच में करें, कहीं भी करें. पर मैं चाहता हूँ ये रेगुलर फीचर होना चाहिए. अगर आप हमारी बातें को सुन लेंगे, जिस तरह के केसेस आते हैं, डॉक्यूमेंटेशन में गलती कर देते हैं, सब कुछ करते हैं, लिखते नहीं. और हमें एज ए डॉक्टर, मुझे एज ए वहाँ पे ज्यूरी पता होता है कि आपने काम किया पर लिखा नहीं है, पर मैं कुछ नहीं कर सकता क्योंकि सामने वाली पार्टी एग्रेसिव है. दे आर नॉट फूल्स. व्हेन दे कम, दे हैव ए डॉक्टर बिहाइंड देम, दे हैव ए लॉयर बिहाइंड देम. तो आप उनको ऐसा नहीं कि आप उनको खूब फूल कर सकते हैं. तो ये चीज़ें बहुत ज़रूरी है. मेरे को लगता है कि हम ऐसा करेंगे तो बहुत फ़र्क पड़ेगा. और डॉक्टर डालमिया, आप एक प्लान बना लो. लेट अस हैव ए मीटिंग विद ऑल द ब्रांचेस एंड प्रेसिडेंट DMA एंड दिल्ली मेडिकल काउंसिल के साथ में, एंड फोर्टनाइट या मंथली या और जल्दी करना चाहे, मुझे कोई दिक्कत नहीं है. हमारे रिसोर्सेज रेडी है. प्लस दिल्ली मेडिकल काउंसिल के वेबसाइट पर जाइए, वहाँ पे सारे मेथड लिखे हैं. मोर देन 15 आर्टिकल्स हैं स्पेशलिटी वाइज, एग्जाम्पल केसेस हैं जो हमारे पास केसेस आते हैं, उनको पढ़िए. उनको पढ़ोगे तो आपको मालूम पड़ जाएगा कि किस तरह की कॉमन गलतियाँ आप लोग करते हैं, ताकि ना करें. ये थोड़ा सा हार्ड हिटिंग था, पर मुझे लगता है इस अपॉर्चुनिटी में बताना ज़रूरी है आप लोगों को, ताकि हमारा DMC का बर्डन भी कम हो जाए और हम भी धर्म संकट में रहें कि अपना दोस्त आगे कैसे बचाएं. इन्हीं शब्दों के साथ मैं विराम लेना चाहूँगा, पर एक बार आपको फिर धन्यवाद.
Thank you, Dr. Arun Gupta. I may want to add here that I'm sure most of you would be aware that the National Medical Commission, which has replaced the Medical Council of India, has recently proposed draft new rules for which would actually govern practice of medicine in India. It's a long 130-page document, and Delhi Medical Association was one of the few organizations in the country which very actively has given very proactive suggestions to modification of the draft. Because keep in mind, once this draft is adopted, it becomes law which will govern practice for all of us. So how and why, I think what Dr. Arun Gupta very rightly said, there are things we need to take care of, but there are also things which the NMC and the DMC need to take care of, so that doctors don't view every patient who walks into the clinic as a potential litigant. With these words, I would now request Dr. Girish Tyagi, Secretary, Delhi Medical Council, please deliver his oration and enlighten us a little more on the roles and responsibilities of the Delhi Medical Council. Dr. Tyagi.
Thank you, Dr. Sanjeev Malik. Dr. Shaijanand Prasad Singh, National President, Dr. Ashwin Dalmia, President DMA, Dr. Arun Gupta, President DMC, and other members, Dr. Vinay Agarwal, past National President, Dr. Ramesh Datta, Dr. Chawla, Dr. Ashwini Goyal, past President, Delhi Medical Association. डॉक्टर अरुण गुप्ता ने जहाँ से कर रहे थे उसी को कंटिन्यू में करते हुए, इफ़ यू आर डूइंग अ एथिकल प्रैक्टिस, अगर आप एथिकल प्रैक्टिस कर रहे हैं, नोबडी कैन टेक एक्शन अगेंस्ट. दिल्ली मेडिकल काउंसिल विल नॉट able to take action even if they think that action can be taken if you are doing the ethical practice. Ethical practice means कि if you are communicating with the patients, writing what is being done, documenting what is being done with the patient care in the records, consent is proper, documentation is proper. If the complication has occurred and if you have informed the patient or the relative about the complication, taken cognizance of that complication, proper care has been taken in treating the complication, result whatever may be, even the death, you will not be convicted by any forum anywhere, not from Delhi Medical Council, from even the National Medical Commission or Consumer Court or Criminal Court will not be able to convict you if you are doing the ethical practice. But the issue is that we are not properly communicating, and simultaneously we are not properly documenting. We on both these aspects, communication as well as documentation, we are lacking far behind. Consent is not proper. Consent हमारे पास जब आती है वहाँ पर consent is blanket, consent is there. Consent पे Supreme Court का judgment है. Samira Kohli was the judgment of the Supreme Court, which state that blanket consent is a invalid consent. ब्लैंकेट कंसेंट कई बार तो कंसेंट के ऊपर डॉक्टर के सिग्नेचर भी नहीं होते, कई बार पेशेंट के रिलेटिव के सिग्नेचर नहीं होते, कई बार उसका व्हाट आर द प्रोसीजर विच आर गोइंग टू टेक इज नॉट मेंशन्ड ऑन द कंसेंट पेपर. सो अगर आपने कंसेंट ही प्रॉपर नहीं है, दैट मीन्स कि क्रिमिनल एक्शन कैन बी टेकन अगेंस्ट यू इफ़ यू आर नॉट प्रॉपरली टेकिंग द कंसेंट. इफ इट इज़ नॉट अ वैलिड कंसेंट, क्रिमिनल कंप्लेंट कैन बी लॉज्ड. दूसरी चीज़, हमने कंसेंट नहीं ली, उसके बाद जब केस जाता है दिल्ली मेडिकल काउंसिल में कहीं पर भी, वी ट्राई टू मैनिपुलेट द रिकॉर्ड्स. जस्ट लिसन टू इट. इफ यू आर मैनिपुलेटिंग द रिकॉर्ड्स, मैनिपुलेटिंग और फोर्जरी इन द रिकॉर्ड्स इज अ क्रिमिनल केस. Criminal case can be lodged if it is found that you are manipulating the record, if some forgery has been committed in the records. So these things, common things, we should avoid. डॉक्टर डालमिया ने जैसे कहा कि वुमेंस का आज का भी ये हमारा वुमेंस का प्रोग्राम, इससे पहले प्रोग्राम हो चुके हैं. डॉक्टर डालमिया से मेरा थोड़ा सा वो मतभेद रहता है कि गिफ्ट के ऊपर, क्योंकि मेरे को लगता है कि जो हम नली साड़ी या डॉक्टर डालमिया का तनिष्क को लेके जा रहे हैं, सिर्फ यहाँ पर लेडीज़ नली साड़ीज़ के लिए नहीं आई हैं, बिकॉज ऑफ आपका कंसेंट, आपका जो टॉपिक था पैलिएटिव केयर का, दैट वाज सो मच इंटरेस्टिंग, इसीलिए लेडीज़ ने आप हमारे पार्टिसिपेट करा है. और अगर हमारे टॉपिक अच्छे होंगे, स्पीकर अच्छे होंगे, नोबडी वांट ए गिफ्ट, नोबडी वांट ए डिनर, नोबडी वांट ए दारू, everybody want to participate if it is a proper function. जैसा कि डीएमए ने कहा कि डॉक्टर डालमिया पे लाछन लगाया गया जब नली साड़ी ले गई, ऐसा ही एक है डीएमए मीन्स की दारू मुर्गा एसोसिएशन, जो कि हम इसको चेंज करने जा रहे हैं. आज के प्रोग्राम में देयर इज़ नो दारू एट ऑल. तो नहीं, हम सर मैं तो डीएमए का प्रेसिडेंट था, मैंने अपने टाइम पे किसी भी प्रोग्राम में ड्रिंक ऑफर नहीं करी, किसी भी प्रोग्राम में किसी इसी तरह की इंसेंटिव या गिफ्ट कहीं पे मैंने प्रमोट नहीं करी। और हम डॉक्टर डालमिया आपसे रिक्वेस्ट है, हम आपसे पूरे 100% आपके जितने भी यहाँ पर ऑडिटोरियम बैठे हैं, जाकी मेंबर्स जो यहाँ पे नहीं भी आए हैं, उनका कमिटमेंट आपके साथ है, बिकॉज यू आर वर्किंग। जिस तरह के डॉक्टर डालमिया वर्किंग कर रहे हैं, आज भी 12 बजे से डॉक्टर डालमिया वाज हेयर एट द दिल्ली मेडिकल एसोसिएशन हॉल। इससे पहले प्रोग्राम में जबकि एसी फंक्शन नहीं कर रहा था, रात को 1 बजे यहाँ से घर से गए, डीएमए से गए हैं घर के लिए एसी रिपेयर करने के बाद। सो बिग क्लैप टू डॉक्टर डालमिया। नहीं, डॉक्टर सुलेखा को पता है बिल्कुल, तभी आपसे वो बड़े आराम से शांति से खड़ी हुई हैं वहाँ पर, सीट भी नहीं मांग रही। तो डीएमए के अगर हम प्रोग्राम अच्छे करेंगे, अच्छे स्पीकर होंगे, अच्छे कंटेंट होंगे, नोबडी वांट आपको सिर्फ चाय पे बुलाइए, वी विल। और अगर आपको ज़रूरत है डीएमए को, वी कैन ऑफर अवर्स, हम अपने डिनर के पैसे खुद दे देंगे, देयर इज़ नो इशू एट ऑल। बट जो ये नली साड़ी और ये जो है, मेरा तो अब भी मानना है कि इसको ज़्यादा प्रमोट ना करा जाए। और लेडीज़ को कम से कम, ये लेडीज़ नली साड़ी नहीं मांग रही हैं आज की डेट में, आप सब ताली बजा के कहिए कि आप आगे के प्रोग्राम में पार्टिसिपेट करेंगे विदाउट एनी नली साड़ी, विदाउट तनिष्क। नहीं, चलो, once again thank you very much for participating in the program and congratulations to Dr. Dalmia and the team for wonderfully organizing it. Thank you very much.
Thank you, Dr. Tyagi. You know, the strength of democracy comes in when you have a difference of opinion. I think most of us are aware that Ashwini Dalmia and Girish Tyagi are one of the closest friends. Love Kush ki jori bolte hain hum inko. And they have a difference of opinion. On a lighter note, the new amended NMC Act also has a provision that after the CME or CPD, as they are going to call it now, will have an opinion poll. If I was aware of this difference of opinion, what I would do is have an opinion poll on whether people want Tanishq or Nali saris or none. With these words in a lighter tone, may I request dynamic, energetic, most committed National President of the Indian Medical Association, Dr. Shahjanand Prasad Singh, to please deliver his chief guest address. And may I request all of you ladies and gentlemen to give him a standing ovation.
ओम नमो भगवते वासुदेवाय। हर लोग को मॉर्निंग में 2-4 बार बोलना चाहिए, जिससे कि ज़िंदगी में किसी तरह के बाधाएं नहीं आए। परम आदरणीय प्रिय डॉक्टर सोनी डालमिया जी जो अध्यक्ष हैं, डॉक्टर अवतार कृष्ण शायद नहीं आए हैं, माननीय सचिव, दिल्ली में आए हुए नेता, डैश पर उपस्थित गणमान्य व्यक्ति, हमारे बड़े भाई संजीव मलिक जी, सचमुच बड़े भाई ऐसा रूल इनका रहता है। मैं इनके साथ बरसों तक IIM में काम किया हूँ एज ए जूनियर। बड़े भाई डॉक्टर विनय अग्रवाल जी, छोटे भाई डॉक्टर अरुण गुप्ता जी, आपने काउंसिल, मेडिकल काउंसिल का पाठ पढ़ाया। मैं आउट ऑफ ट्रैक्ट एक बात कहना चाहूँगा, 20 वर्षों से मैं बिहार मेडिकल काउंसिल का रजिस्ट्रार हूँ और अभी तक हमने किसी को दंड नहीं दिया। आपकी जोड़ी बहुत अच्छी जोड़ी है, त्यागी जी का और आपका, आपसे मेरा एक करबद्ध प्रार्थना है, छोटी मोटी गलती तो होती है, इसमें कृपया डॉक्टरों को दंड नहीं दें। देखिए, डॉक्टर बहुत परेशान रहता है, लेकिन डॉक्टर घर का काम करना, बाहर का काम करना, बच्चों को देखना, तो रिस्क बॉन्ड भी ठीक से नहीं लिखवा पाती हैं, तो कुछ गलतियां रह जाती है। आप लोग दोनों बहुत अच्छे हैं और आपसे उम्मीद है कि आगे किसी का रजिस्ट्रेशन कैंसिल ना करें। सर, हमने अभी तक किसी का रजिस्ट्रेशन कैंसिल नहीं किया है। हमारे विनय जी को पता होगा और हमारे भाई बिहार के कुछ डॉक्टरों का मेडिकल काउंसिल ऑफ इंडिया ने लगभग 50-60 डॉक्टरों का रजिस्ट्रेशन कैंसिल कर दिया था। कोई यहाँ घूमने गए, कहीं बाहर घूमने गए और बहुत तेज़ी से, गलती से, उस ज़माने में एक हमारे बड़े भाई जो पास्ट प्रेसिडेंट थे, एथिक्स कमेटी के मेंबर थे, शायद विनय जी थे कि नहीं थे, लेकिन उसके बाद विनय जी एथिक्स कमेटी के मेंबर बने और सबों का इन्होंने रजिस्ट्रेशन कैंसिल कर दिया। सर, जो विदेश से नहीं गया है, जिसका पासपोर्ट में एंट्री नहीं है, और उसका भी रजिस्ट्रेशन कैंसिल किया गया। भाइयों, ऐसे ऐसे डॉक्टरों जो बिहार लेवल पर बहुत उच्च कोटि के फिजिशियन माना जाता है, डॉक्टर BK अग्रवाल बहुत बड़े फिजिशियन है, उनका दिया गया, US रहा है और ऊपर वाले की कृपा सर 50 से 50 डॉक्टरों को हमने बचा लिया। मेडिकल काउंसिल ऑफ इंडिया कुछ नहीं कर पाई, कुछ लोग हाई कोर्ट भी गए, हाई कोर्ट में भी हम फाइट करके 50 को बचा लिया। सर, आप दोनों को बहुत, आपके ऐसा भला जेंटिल बहुत कम लोग हैं सर, जिस तरह से आप मोबिलाइजिंग हैं समाज में। इन लोगों पर जरूर ध्यान रखिए। बहुत मेहनत से डॉक्टर बना है और जब रजिस्ट्रेशन कैंसिल हो जाएगा बॉस तो कहीं का नहीं रहेगा। इसलिए आपको दोनों को, राम लक्ष्मण की जोड़ी को मैं प्रार्थना करता हूँ कि आज से किसी को दंड ना दें। प्रशांत जी, यूसी बंसल जी, शरानी जी, डॉक्टर ठाकुर, त्यागी जी बोल दिए हैं, वाक्य गोयल जी, लेडी डॉक्टर में सीमा जी, दिव्या जी, सुषमा जी, ज्योति जी, उषा जी, देवी सज्जनों, दिल्ली मेडिकल एसोसिएशन द्वारा आयोजित महिला सम्मेलन का उद्घाटन करते हुए मुझे बहुत हर्ष हो रहा है। कुछ दिन पहले आए में महिला 100 जून का सम्मेलन केरल में आयोजित हुआ था, मैं वहाँ गया था। वहाँ इस तरह की गैदरिंग नहीं थी, वहाँ लोग आई थी लेकिन दिल्ली का कोई जोड़ा नहीं है। जैसा कि आप सभी जानते हैं कि महिला डॉक्टर न केवल हमारे चिकित्सा पेशे में बल्कि डॉक्टरों के साथ लाभ के लिए महत्वपूर्ण कार्यक्रमों में आयोजन से भी एक महत्वपूर्ण कार्यबल बनाती है। आज के साइंटिफिक सेशन में पैलिएटिव केयर, ऑन्कोलॉजी से संबंधित अन्य विषयों पर बहुत महत्वपूर्ण विशेष शामिल हैं। प्रत्येक सामान्य चिकित्सक को जानना चाहिए। राष्ट्रीय और राज्य स्तर के महिला डॉक्टरों को प्रोत्साहित करने में, उनकी भागीदारी शामिल करने में महिला डॉक्टर विंग IMA में बहुत अच्छा काम कर रही है। महिला सशक्तिकरण पहले से भी IMA की विचारधारा में था। IMA के दिसंबर 2015 में नई दिल्ली में आयोजित सेंट्रल काउंसिल में पहले ही संकल्प लिया गया था कि IMA में लगभग 10% महिला सदस्य होंगी। 5 सितंबर शिक्षक दिवस आने वाला है। 5 सितंबर शिक्षक दिवस आने वाला है। मैं दिल्ली के जो मेन प्रेसिडेंट सेक्रेटरी हैं उनसे मैं आग्रह करूंगा कि यहाँ से भी 2-3 जो टीचर्स रहे हैं जो IMA में FCGP में एकेडमी में काम किए उनमें से नाम भेजा जाए, जिससे कि हम लोग उनको प्रोत्साहित करें। 2-3 बात मैं कहना चाहूँगा। IMA आपके साथ है और बहुत सा कार्य आपके लिए किया है। 5-7 पेंडिंग काम जो था उसको हम लोगों ने किया है, जिसमें विनय जी भी साथ गए थे और भी बहुत से डॉक्टर थे, रवि वानिटकर वगैरह सभी लोग हम लोग मंत्री के यहाँ मिले। और सबसे पहला मांग था कि BC राय अवार्ड जो बंद है उसको शुरू किया जाए, और उसको शुरू किया गया। मैं माननीय हेल्थ मिनिस्टर को इसके लिए कॉन्ग्रेचुलेट किया और मैं बधाई उनको दिया कि आपने बहुत बड़ा काम किया। दूसरा, वायलेंस एंड द डॉक्टर्स के बारे में भी उन्होंने कहा है कि पैंडेमिक के समय जो प्रावधान था उसको एंडेमिक करेंगे, सब दिन के लिए करेंगे। क्लिनिकल एस्टेब्लिशमेंट एक्ट जो आपके हेल्थ मिनिस्टर अभी तो नहीं है, गुजरात गए थे, उन्होंने एश्योर किया था कि 50 बेड हॉस्पिटल को एग्जाम्प्ट करेंगे क्लिनिकल एस्टेब्लिशमेंट एक्ट से। अभी जो हेल्थ का चार्ज लिए हुए हैं डालमिया जी, उनके यहाँ जाकर प्रेशर दे कि 50 बेड हॉस्पिटल को क्लिनिकल एस्टेब्लिशमेंट एक्ट से एग्जाम्प्ट किया जाए, जिससे कि लोग आज भी जो छोटे छोटे हॉस्पिटल में काम करते हैं वही रीढ़ हैं हमारे प्रैक्टिस और गरीब जनता के लिए। तो इसको सर्व करवा देंगे। बिहार में भी लगभग हो गया है, नोटिफिकेशन स्टेज में है। उत्तर प्रदेश में हो गया है, 50 बेड तक के हॉस्पिटल में क्लिनिकल एस्टेब्लिशमेंट लागू नहीं हुआ है। हरियाणा में हो गया है, अब मोस्ट ऑफ दी स्टेट में होने वाला है। इसको सर एक करवा दीजिएगा। तो आप तो प्रभावशाली व्यक्ति हैं, आपके इतना मेहनत करने वाला बहुत IMA के डॉक्टर हैं, आप इसको आप करवा सकते हैं, ऐसा विश्वास है। आप तो यहाँ रहते हैं, 5-6 आदमी जाके मिलिए, 2-4-5 बार तो ये काम हो जाएगा। CPA में भी हो जाएगा। CPA तो ऑलरेडी रामविलास पासवान जी ने कर रखा था और पार्लियामेंट से राज्यसभा से भी पास हो गया था, लेकिन IAS लोगों की कृपा के चलते एक्सेप्ट डॉक्टर नहीं जोड़ा गया। इसकी भी उम्मीद है जो हो जाएगा। माननीय डिफेंस मिनिस्टर राजनाथ जी भी ने कहा है, उनसे भी मिले थे, उन्होंने कहा है कि मैं भी हेल्थ मिनिस्टर से कहूँगा और होम मिनिस्टर से कहूँगा, आपका सारा काम हो जाएगा। तो मैं आप सबों के लिए, डॉक्टरों के लिए और सबके हित के लिए जहाँ तक हो रहा है काम कर रहा हूँ। लास्ट में सर मैं इस तरह का यूनाइटेड सीन पहले दिल्ली में नहीं होता था जो अभी है। और मैं यहाँ जो पास्ट प्रेसिडेंट बैठे हैं और हमारे डालमिया जी बैठे हैं, हर सब्जेक्ट पर 2-3 नाम पहले से ही बॉस के यहाँ भेज दें। बॉस हम लोग चीफ पैटर्न को करते हैं, जो शायद सुन रहे होंगे, चीफ पैटर्न के यहाँ भेजा जाए और तब हम समझते हैं कि उसमें जिसको बॉस टिक लगा दे उस पर हम लोग कंसंट्रेट करके काम करें, तो आपका सेक्रेटरी जनरल भी दिल्ली का हो जाएगा। सेक्रेटरी जनरल दिल्ली का होना बहुत ज़रूरी है सर। हम कई एक बार बॉस से भी कहा है और आप सबों से भी कहा है कि देखिए, राम बाबू बहुत दिनों तक थे, श्याम बाबू दिनों थे, आते हैं जाते हैं, इससे काम नहीं हो पाता है। फॉलो नहीं हो पाता। हम लोग मंत्री साहब वो लोग फॉलो नहीं कर पाते हैं, तो यहाँ के लोग रहेंगे तो उसको फॉलो करेंगे, काम होगा। और भी जो भी पोस्ट आपका ज्वाइंट सेक्रेटरी और असिस्टेंट सेक्रेटरी का है, ट्रेजरर का है, सर मिल बैठ करके नाम भेजें और चीफ पैटर्न के यहाँ से अप्रूवल लेके काम करें। इस बार भी इलेक्शन नहीं होने की संभावना है। हमारे चीफ पैटर्न साहब, देसाई साहब इस पर भी अलर्ट हैं कि एक बार इलेक्शन का मतलब 30-40 लाख रुपया खर्च होना। तो उससे बचने का भी यही है कि हम लोग मिलजुल करके हर पोस्ट पर 2-3 नाम भेज करके वहाँ से अप्रूवल लेकर काम करें। लीडर सर मन में बात को भुलाते हुए कि उनका आदमी है, मेरा आदमी है, हर आदमी सबका है। और मेरा डॉक्टर समाज बहुत अच्छा समाज है सर। यदि ऐसा नहीं होता कि माननीय देसाई साहब के अम्ब्रेला के नीचे काम करते हुए एक किसान के बेटा को आपने प्रेसिडेंट बनाया, इसमें आप लोग का आशीर्वाद है। आप लोग का आशीर्वाद नहीं होता तो ऐसा संभव नहीं था। तो इसी तरह से यहाँ भी ऐसा करिए कि सेक्रेटरी जनरल दिल्ली का होना बहुत बहुत ज़रूरी है, तब आपका काम निकलेगा। नहीं तो दिक्कत क्या है, काम ठीक से निकल नहीं पाता। अब हम मंत्री से मिल के आए, कोई फॉलो करने वाला नहीं है। और जो ज्वाइंट सेक्रेटरी, असिस्टेंट सेक्रेटरी यहाँ के हैं दिल्ली वाले, उनका हमने चैम्बर बनवा दिया है। चावला साहब वहाँ भी थोड़ा बैठा करिए, रमेश दत्ता जी आप भी वहाँ जाइए, जो भी हैं, और कामत साहब हैं, सबका रूम वहाँ लगभग बन गया है। बैठिए, चाय चुय पीजिए, कुछ काम करिए। आइए सर, मोंगा साहब बैठिए। तो आप जितने भी अच्छे पद पर के लोग जाने वाले हैं, लगभग यहाँ सब बैठ गए, आकर बैठे हुए हैं। अब तो बैठे हैं, इधर बैठे हैं, सब मिलजुल कर ऐसा करिए सर जो मैं बिहार में करता हूँ। 30 सालों से कोई इलेक्शन बिहार में नहीं हुआ है, 30 इयर्स। और ना मेडिकल काउंसिल, स्टेट मेडिकल काउंसिल में होता है, और ना IMM होता है। नेशनल मेडिकल कमीशन में मैं परमानेंट मेंबर हूँ, और पूरे बिहार के लोगों ने चुन के भेजा। यही माहौल यहाँ बनाइए तो मजा आ जाएगा। अंत में यही कहूँगा, हम सभी मिलकर रहेंगे और IMA के लिए काम करेंगे। बहुत बहुत धन्यवाद। जय IMA।
Intro to our chief guest, Dr. SNP Singh. That's a representation of our love and affection for the national president. Dr. Prashant Seth to please present a memento to Dr. Arun Gupta, President, Delhi Medical Council. And Dr. Popley to please present a memento of love and affection to Dr. Girish Tyagi, Registrar, Delhi Medical Council. Thank you, ladies and gentlemen. We now move on to the awards function. A symbol and tribute of the Delhi Medical Association to our women colleagues. I would request the awardees to please speed up because we have a host of awardees. And I would also request, I will announce the name of the following awardee. sequence is the sequence in which you arrived at DMA, so it shouldn't be misconstrued as anything else. Dr. Amita Agarwal. Next would be Dr. Anita Kaushik. Please be ready. Dr. Amita Agarwal is a senior CMO working at various hospitals and dispensaries attached to the Municipal Corporation of Delhi. Dr. Anita Kaushik. Dr. Deepmala Lalchandani would follow, please. Dr. Anita Kaushik is practicing in Paschim Bihar, an extremely passionate, caring doctor. Dr. Indu Mehra to be ready after this. Dr. Deepmala Lalchandani, a former Deputy Medical Superintendent and Head of Office in Senior Dada Dev Maternity and Child Hospital since 2015. Dr. Indu Mehra and Dr. Jonas Sankla would follow. I would request all awardees to please come up from the right side of the dais and move down from the left side. Dr. Indu Mehra, presently working in MCD as CMO, SAG, posted at Maternal and Child Welfare Center, Mangolpuri. Dr. Junu Sankla, Dr. Sukriti Bhalla and Dr. Kusum Serene would follow. Dr. Junu Sankla is a senior medical officer at Sardar Vallabhbhai Patel Hospital. Dr. Sukriti Bhalla, Madam would request please move down from that side of the stage. Dr. Sukriti Bhalla is a consultant interventional cardiologist at the Akash Healthcare Hospital, Dwarka. Dr. Kusum Serene would follow, and Dr. Neelam Sehgal and Dr. Mani Kapoor after that. Dr. Kusum Serene, a senior consultant, a very old member of the medical profession, committed to the profession. Dr. Neelam Sehgal, with a practice record of over 46 years, a past president of Lady Harding Sadar Paharganj Bahan. Dr. Mani Kapoor and Dr. Pooja Gupta and Dr. Pooja Relia after this, please be ready. Dr. Mani Kapoor, a renowned IVF expert, owns the Healing Touch hospital chain. Dr. Pooja Gupta, again a senior consultant with BL Kapoor Hospital, Cloud9, Fortis Hospitals. Dr. Pooja Relia, Dr. Praveen Suman, in that order after this. Dr. Pooja Relia, senior consultant. Dr. Praveen Suman, Dr. Veena Acharya. Dr. Praveen Suman, again a senior member of the profession, dedicated to the cause of patients. Dr. Veena Acharya, Dr. Savita Puri, please after this, Dr. Veena Acharya, a senior consultant working in the IVF department at Sir Gangaram Hospital. Dr. Alpna Srivastav, Dr. Mamta Thakur after this. Dr. Savita Puri, a senior practicing physician and gynecologist. Dr. Alpna Srivastav, Dr. Mamta Thakur and Dr. Mrik Kashi Agarwal after this. Dr. Alpna Srivastav is a senior pathologist, worked in various organizations like Wellspring Labs. Dr. Mamta Thakur, a senior practicing gynecologist of East Delhi. Dr. Mrik Kashi Agarwal, Dr. Pallavi Sugandh and Dr. Rama Sharma, please Dr. Mrik Kashi Agarwal, a senior consultant in pulmonology and critical care at the Sanjeevan Hospital. Dr. Pallavi Sugandhi, a senior ophthalmic surgeon, expert in cataract, LASIK at the Complete Eye Care Center. Dr. Rama Sharma, Dr. Rekha Jain, Dr. Ruby Makhija in that sequence after that. Dr. Rama Sharma is a senior practicing gynecologist with more than 30 years experience practicing in North Delhi. Dr. Rekha Jain, again a senior gynecologist presently with the Hindu Rao Hospital in the senior administrative grade. Dr. Ruby Makhija, Dr. Ruchi Agarwal, Dr. Shelly Jain, please be ready. Dr. Ruby Makhija, a senior practicing ophthalmologist for more than 20 years, presently runs a free eye clinic in Delhi. Dr. Ruchi Agarwal, Dr. Shelly Jain, Dr. Yashoda Kura, please be ready. Dr. Ruchi Agarwal, consultant and runs the Arogya Ruchi Hospital in Najafgarh. Dr. Shelly Jain, presently working as specialist grade 1 in the Jag Pravesh Chandra Hospital. Dr. Yashoda Kura, Dr. Anjali Nijara and Dr. Kirti Nirmal after this. Dr. Yashoda Kura, a senior consultant working voluntarily to provide free professional aid to patients. Dr. Anjali Nijara, please. Dr. Kirti Nirmal, Dr. Avdesh Singh after this. Dr. Anjali is a senior consultant obs and gynae practicing at the Nijara Hospital for 2.5 decades now. Dr. Kirti Nirmal, a senior consultant again committed to cause of patients. Dr. Avdesh Singh, Dr. Chandarlata to be ready after this. Dr. Avdesh Singh, a senior consultant dermatologist practicing in Dwarka, heads the Skin and Child Care Center. Dr. Chandar Lata, Dr. Kavita Katoch and Dr. Deepa Gupta to please be ready. Dr. Chandar Lata is a senior gynecologist with the Max Hospital. Dr. Kavita Katoch, Dr. Deepa Gupta, Dr. Anju Malhotra in that sequence. Dr. Kavita Katoch, practicing in South Delhi at the Holy Angels Hospital, now attached to Birthright, Rainbow and South End Fertility. Dr. Deepa Gupta, a senior consultant gynecologist, also presently the finance secretary of the IMA's Delhi branch. Dr. Anju Malhotra, Dr. Kanta Meena, Dr. Vibhavari Bhutani. Dr. Anju Malhotra is a senior consultant clinical oncology at the Park Hospital. Dr. Kanta Meena, the senior anesthetist at the BLK Max Super Speciality Hospital. Dr. Vibhavari Bhutani, Dr. Namrata after this. Dr. Vibhavari is an ENT consultant at the Bhutani Eye and ENT Clinic, Rajouri Garden. Dr. Namrata Makkar and Dr. Rekha Khandelwal after this, please. Dr. Namrata Makkar, Dr. Rekha Khandelwal, Dr. Sandeep Chaudhary, Dr. Shakuntala Srivastav in that sequence, please. Dr. Namrata is the medical superintendent of a 650-bedded super speciality hospital under Delhi government. Dr. Rekha Khandelwal, Dr. Rekha Khandelwal, a senior consultant, senior member of the profession. Dr. Sandeep Chaudhary, Dr. Shakuntala Srivastav, Dr. Randhir Dhaliwal. Dr. Sandeep Chaudhary, please, Director Center for Fetal Medicine at Dr. Rajiv's Ultrasound Lab, a former secretary and president of IMA Janakpuri. Dr. Shakuntala Srivastav, senior consultant, done a tremendous job for patients. Dr. Randhir Dhaliwal and Dr. Yukti Vadhavan, Dr. Neeru Agarwal after this. Dr. Randhir Dhaliwal, a gynecologist with nearly 3 decades of experience practicing in West Delhi. Dr. Yukti Vadhavan, Director of L'Original IVF, a senior gynecologist. Dr. Neeru Agarwal, Dr. Neelam Garg, Dr. Kiran Arora. After this, please. Dr. Neeru Agarwal, dressed up for the cultural function, a senior consultant gynecologist. Dr. Neelam Garg. Dr. Neelam Garg, she was here. Oh yes, so don't mistake all these senior gynecologists for artists. You know, they are artists come senior gynecologists. Welcome Dr. Neelam Garg, a senior consultant gynecologist. Dr. Kiran Arora, Dr. Manju Gupta, Dr. Neerja Goyal after this. Dr. Kiran Arora, a senior member of the profession. Manju Gupta. Dr. Manju Gupta, Dr. Neerja Goyal, Dr. Shabnam Singh after this please. Dr. Manju Gupta is a senior member of the IMA South Delhi branch, actively participates in all social and welfare activities. Dr. Neerja Goyal, Dr. Shabnam Singh, Dr. Shubh Kamal Java after this, please be ready. Dr. Neerja Goyal, a senior practicing gynecologist in Dilshad Garden. Dr. Shabnam Singh, Dr. Shubh Kamal Java, Dr. Neelu Gandhi. Dr. Shabnam Singh is the Principal Advisor Healthcare of CII, the founder member and currently advisor and governing board member of the Health Sector Skills Council and Life Sciences Sector Skills Council. Works actively with the Confederation of Indian Industry. Dr. Shubh Kamal Java, a senior consultant gynecologist, runs and manages the Java Nursing Home. Dr. Neelu Gandhi, Dr. Meera Gupta, Dr. Vijay Mehta, please be ready. Dr. Neelu. Yeah, we'll give you enough opportunities for photo shoots. Dr. Shubh Kamal Java. हो गया? Dr. Neelu Gandhi, a senior gynecologist, senior medical officer with Delhi University, one of the founder members of the medical legal cell of IMA's Delhi branch. Dr. Meera Gupta, again a senior gynecologist of West Delhi with over 3 decades of experience. Dr. Vijay Mehta, 4.5 decades of contribution to practice in Ashok Vihar, presently a blood bank in charge of the Loyens Blood Bank. Dr. Dipali Taneja and Dr. Nirupama Tyagi, please after this. Dr. Dipali Taneja, Dr. Dipali is a senior anesthesiologist with the Deen Dayal Upadhyaya Hospital. Dr. Nirupama Tyagi, again a senior consultant with decades of contribution to the medical profession. Well, those were names of the awardees I had from your entry register. But there are some others, if they are here. Dr. Anju Malik, Dr. Ashima Bhatia, Dr. Anju Malik is here. Sir, request silence. I think just few more minutes to give honors. Dr. Anju Malik, a senior pediatrician. Dr. Alka Chandra. Dr. Alka Chandra is head of department at the Hindu Rao Hospital and the NDMC Medical College, former HOD at RBI PMT. Dr. Anju Malik, we've done. Dr. Ashima Bhatia, is she here? Dr. Dipali Taneja. Dr. Jyoti Bali. Dr. Manju Sahi. Dr. Nirupama Tayagi. Dr. Nomita Gupta. Dr. Poonam Singh. Doctor? Dr. Poonam Singh, a gynecologist, runs her own polyclinic at Anand Parbat. Dr. Renu Bali. Dr. Renu is head of Department of Internal Medicine at the Deep Chand Bandhu Hospital. Dr. Ruchira Jain. Dr. Ruchira Jain is there? Yes. Dr. Ruchira is a senior practicing family physician in Ashok Vihar area. Dr. Sojanya Agarwal. Dr. Sujata Bakshi. Dr. Sunita Mehta. Dr. Veena Laroia and Dr. Shilul Gupta. All right, thank you very much. Thank you for being a very patient audience. May I now request Dr. A.S. Popley, our Finance Secretary, to deliver the formal vote of thanks, which would be followed by a cultural program and dinner. Dr.
ब्यूरोक्रेटिक कंट्रोल था, उसमें भी डीएम एसडीएम लोग रहेंगे, डॉक्टर्स का रोल नहीं था. सेकंड सबसे इम्पोर्टेंट जिस पे हमें ऑब्जेक्शन थी वो थी इमरजेंसी केयर का क्लॉज था. तो जब हमारी गवर्नमेंट में बात चली कैसे करना, तो क्योंकि जो हेल्थ मिनिस्टर इज़ वेरी क्लोज टू मी, तो उन्होंने 8 लोग कमेटी बनाई थी, उसमें से 4 हम में थे. उन्होंने कहा अपनी कमेटी बना के खुद ही बना लो. तो डॉक्टर के अग्रवाल थे उस कमेटी में, डॉक्टर चंद्र प्रकाश थे, डॉक्टर राकेश गुप्ता थे और मैं था. हम 4 लोग थे. तो हमने अपना बिल बनाने की कोशिश की. तो हमने क्लिनिकल इस्टेब्लिशमेंट एक्ट को बिल्कुल हटा दिया है. दिल्ली में लगेगा ही नहीं वो पूरा का पूरा, बिल्कुल हटा दिया है. बिल्कुल भी लगने नहीं देंगे किसी हालत में. 7 साल हो गए मैं बैठा हूँ यहाँ पे. एक मिनट, एक बता दूँ अश्विनी, बहुत इंपॉर्टेंट, इतने सारे लोग बैठे ना, एक डांस कुछ शॉर्ट में हो जाएगा. नहीं, यू मस्ट नो कि क्या चल रहा है, क्योंकि सर उसका क्लैरिफिकेशन ज़रूरी है. हमने पूरा का पूरा हटा दिया है। अब जो बिल दिल्ली में हेल्थ बिल नाम से आ रहा है, पहली बात तो टॉप टू बॉटम डॉक्टर्स चलाएंगे, ब्यूरोक्रेट्स को कहीं रखना ही नहीं है इसके अंदर, क्लियर है। दूसरा, इमरजेंसी क्लॉज को में जो स्टेबलाइजेशन का फैक्टर था कि हर डॉक्टर की जिम्मेवारी कोई भी पेशेंट आए स्टेबलाइज करना, वो हम लोग कर ही नहीं सकते प्रैक्टिकली, तो उसको हटा करके मैंने उसमें खाली फर्स्ट एड करवा दिया है। फर्स्ट एड देना वो भी डिपेंडिंग अपॉन माई प्रोफेशनल कैपेबिलिटी एंड फैसिलिटीज अवेलेबल, उसको बैठवा दिया है। और पेनल्टी क्लॉज को डायल्यूट कर दिया, तो दिल्ली में हम लोग अलग फॉर्म में लाएंगे, तो बिल्कुल डरने की जरूरत नहीं है।
थैंक यू डॉक्टर सैजनानंद प्रसाद सिंह जी। हमारे 3 महीने के अंतराल में कार्यक्रम के दौरान आप 2 बार DMA में आए। थैंक यू आवर गेस्ट ऑफ ऑनर्स, थैंक यू ऑल लवली वुमेन। एक बात कहना चाहता हूँ, देयर वाज ए मैसेज गोइंग ऑन कि come and join Women Day conference for the spouses, for the men, and motivate them. You women, you don't need any motivation, you motivate us. Thank you all, and please wait for the cultural show followed by dinner. And I want to support the support staff, thank the support staff of DMA, Rashmi, Tapas, Satendra and all for all their hard work. And special thank to Dr. Seema Patni, the chairperson of today's event. And one more thank, that lady deserves a thunderous applause, the first lady of the house, Dr. Sureka, for sparing this gentleman for us. Thank you.
Now shortly we'll start the second part of this conference. I'm sure you're enjoying the day, and now you will have a blast. Just wait with us for 2 to 5 minutes. That's
देवा गणपति देवा मंगलम गणेशम। देवा हो देवा गणपति देवा मंगलम गणेशम। देवा हो देवा गणपति देवा मंगलम गणेशम। देवा हो देवा गणपति देवा मंगलम गणेशम। विघ्न विनाशक जन सुखदायक, विघ्न विनाशक जन सुखदायक मंगलम गणेशा।
देवा हो देवा गणपति देवा मंगलम गणेशम। देवा हो देवा गणपति देवा मंगलम गणेशम। मम गम 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 गसा दद मदद मदद मदम ग निनि धनि 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 धम गम धनि सा गम धनि सा गम धनि सा गम धनि सा।
Jalva, Jalva. Yo, blaze up the walk, light it up to the beat. Come on.
আশ্বিন ফাগুন মাসে পরাণ ঘাসে নতুন বিয়ের ফুল ফুটিছে।
উথালি পাথালি মনে আলতা কোণে নতুন বিয়ের ফুল ফুটিছে।
আশ্বিন ফাগুন মাসে পরাণ ঘাসে নতুন বিয়ের ফুল ফুটিছে। উথালি পাথালি মনে আলতা কোণে নতুন বিয়ের ফুল ফুটিছে। এই হো পিয়ালি রে, এই হো দুলালি রে, এই হো পিয়ালি রে, এই হো দুলালি রে। আসিল ফাগুন মাসে পরাণ ঘাসে নতুন বিয়ের ফুল ফুটেছে। উথালি পাথালি মনে আলতা কোণে নতুন বিয়ের ফুল ফুটেছে। ইনি বিনি টাপাটিনি টানা টুনি টাসা, সাহেব বাবুর বউ এসে দেখতে ভারী খাসা। ধুলো কুটি গৌরী হেন ঝি, তোর কপালে বুড়া বর করবো আমি কি। নকশা কাটা পানের বাটা, মুখ ঢেকেছে সুখ সায়রের কোণে। ওপার কাটা চন্দন বাটা, সুহাগ রাতের পেশাদ সবার জন্যে। ইনি বিনি টাপাটিনি টানা টুনি টাসা, সাহেব বাবুর বউ এসে দেখতে ভারী খাসা। উলো কুটি ধুলো কুটি গৌরী হেন ঝি, তোর কপালে বুড়া বর করবো আমি কি। আশ্বিন ফাগুন মাসে পরাণ ঘাসে নতুন বিয়ের ফুল ফুটেছে। উথালি পাথালি মনে আলতা কোণে নতুন বিয়ের ফুল ফুটেছে। ঢাকাই শাখা নৌকো আঁকা, গাঙের জলে ভাসে ঘুঘু শৈল। পালকি চড়ে নদীর ছড়ে, ডাগর চোখের মিষ্টি নগর কইল। ইনি বিনি ডাবাটিনি টানা টুনি টাসা, সাহেব বাবুর বউ এসে দেখতে ভারী খাসা। উলো কুটি ধুলো কুটি গৌরী হেন ঝি, তোর কপালে বুড়া বর করবো আমি কি। নতুন বিয়ের ফুল নতুন ঝিঙে ফুল, বাঁধলো সফি চুল বিবিয়ানা। নতুন বিয়ের ফুল নতুন কানের দুল, देखो क्या रंग लाई है, हाथों की मेहंदी भी जैसे खिलखिलाई है। रात की रंगीनी देखो क्या रंग लाई है, हाथों की मेहंदी भी जैसे खिलखिलाई है। दोस्तियों ने आँख यूं खोली, ओ झूमती धड़कन ये बोली, बल्ले 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 नाचे है ये बावला जिया, बल्ले बल्ले ले जाएगा सावला पिया, चले चले नैनों में जैसे प्यार का दिया। बल्ले बल्ले नाचे है ये बावला जिया, बल्ले बल्ले ले जाएगा सावला पिया।
स्टार्ट होने लगा तुम भी ना ढोल दे ना इश्क नॉन स्टॉप।
Slow it down.
एक तेरे संग यारा अख लड़ने लगी, अख लड़ लड़ के आगे बढ़ने लगी। एक तेरे संग यारा अख लड़ने लगी, अख लड़ लड़ के आगे बढ़ने लगी। ओ तेरे दिल के इशारे ये तो पढ़ने लगी, अख लड़ लड़ के आगे बढ़ने लगी। ओ मुंडा जिद पे अड़ा, ओ तेरे पीछे पड़ा, बड़ा मेरे नाल कर ले जरा। दिल देना दिल लेना, दिल देना दिल लेना, है सौदा है सौदा है सौदा करा करा, है सौदा करा करा, है सौदा करा करा। Jalva, Jalva.
Yo, blaze up the walk, light it up to the beat. Come on, Jalva. Give it to me, Jalva. Give it to me, Jalva. Gorgeous with attitude and every latitude. Miss hot booty, come on, baby, do your duty work.
जिस्मों का है ये जलवा, किस्मों का है ये जलवा, शोहरत भी दे ये जलवा, मकसद भी दे ये जलवा।
Tell him like it is, I can't hear.
दिलकश लगे ये जलवा, मैं कश लगे ये जलवा, नशा ही नशा ये जलवा, मजा ही मजा, नशा ही नशा।
Throw it up, throw it up.
आग सी रवानियाँ,
I know a lot of y'all wouldn't expect it.
लेती गए अंगड़ाइयाँ,
Yo, I'm the hottest girl around.
ये जला दे दिलों में। અને ભૂલો બધી વાત પ્રેમની मौसम छे अब आओ मेरे पास रह जाओ मेरे साथ मौसम छे होई गई रात मन भूलो बदी बात प्रेमनी मौसम छे अब आओ मेरे पास रह जाओ मेरे साथ प्रेमनी मौसम छे मिल जाए मुझको अगर साथ तेरा तो भूलूं मैं सारा गाड़ा तारा छबीला तारा रंगीला तारा रंग वेद जुए तारी बात गाड़ा तारा ओए छबीला तारा ओए रंगीला तारा रंग वेद जुए तारी बात रे गाड़ा तारा ओए छबीला तारा ओए रंगीला तारा रंग वेद जुए तारी बात रे छुप के तुम्हें देखा मैं करूं सारी सारी रात सारी सारी रात
छुप छुप के मुझे देखा तू कर सारी सारी रात सारी सारी रात
मिल जाए मुझको अगर साथ तेरा तो भूलूं मैं सारा जो गाड़ा तारा छबीला तारा रंगीला तारा रंग वेद जुए तारी बात जो गाड़ा तारा ओरे छबीला तारा ओरे रंगीला तारा रंग वेद जुए तारी बात रे जो गाड़ा तारा ओरे छबीला तारा ओरे रंगीला तारा रंग वेद जुए तारी बात रे
हो लीड़ा
पानी सैयरू ने खिंच लई गरबी घुमो ढोल डाना ढोल बाजा धम 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 धमक धम
ढोलीड़ा ढोलीड़ा
धम धम धमक बजे
ढोलीड़ा
धम धम धमक बजे
गज गज रे ढोल पे हवा ढोलीड़ा
धम धमक बजे
ढोलीड़ा धम धमक बजे
बिगड़ा जाए जरा जरा दिल मेरा खुल के नाचूं शर्माए दिल मेरा कैसे समझोड़ गए हो सारा रे ढोल पे नशा
ढोलीड़ा
धम धम धमक बजे
ढोलीड़ा
धम धम धमक बजे
ढोलीड़ा
धम धम धमक बजे
गज गज रे ढोल पे हवा
मारी मारी कमर मारी आरा सुरमा अमराजे आवा गणना ढोकर मारी आकाली धरणम कावागे
मारी तारू रूप निरालू मारी रूप न तू अंबर ए चंदा सूरज तारा लिया गाए तारा गुण हजार खम्मा खम्मा मारी मावरणी तुझे जगनी तारण यार ए जोगी लाना डूंगर वाली चंडी चामुंडा बिरदानी ए चंडी चामुंडा बिरदानी जलवा जलवा
Yo, blaze up the walk, light it up to the beat. Come on,
जलवा
give it to me.
जलवा
Give it to me.
जलवा
Gorgeous with attitude and every latitude. Miss Hot Booty, come on, baby, do your duty work.
जिस्मों का है ये जलवा किस्मों का है ये जलवा शोहरत भी दे ये जलवा मकसद
Sonia Chi,
रुप्यात भिजले रत्न प्रभातनुल्याने नटली थटली जशी उमटली चांदणी रंग महाली मी यवन बिजली पाहून थिजली इंद्र सभा भवतानी
Jalva, Jalva, yo blaze up. Hey, pretty lady, should really know. Oh, little shady, just take it really slow.
सजना है मुझे सजना के लिए सजना है मुझे सजना के लिए जरा मुझे लटे सवार लो हर अंग का रंग निखार लो सजना है मुझे सजना के लिए सजना है मुझे सजना के लिए
गुलशन में गुल खिलते हैं जब सहरा में मिलते हैं गुलशन में गुल खिलते हैं जब सहरा में मिलते हैं मैं और तू
गोरी 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 कभी कभी कहीं कहीं चोरी चोरी गोरी 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 कभी कभी कहीं कहीं चोरी चोरी छुप छुप के तुम मिला करो प्यारी प्यारी बातें बातें किया करो पर यूं ना मिलना किसी से कभी हमारे सिवा
गोरे 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 फूले फूले नए नए गोरे गोरे देखो देखो हम दोनों मीते हैं सुन सुन दिल के जो गीत हैं पर सुनने पाए इन्हें ना कोई हमारे सिवा अच्छा तो हम चलते हैं
फिर कब मिलोगे
जब तुम कहोगे
जुमेरात को
हाँ हाँ आधी रात को
कहाँ
वहीं जहाँ कोई आता जाता नहीं वहीं जहाँ कोई आता जाता
raise up the walk, light it up to the beat. Come on. Jalva. Give it to me. Jalva. Give it to me. Jalva. Gorgeous with attitude in every latitude. Miss Hot Booty, come on baby, do your duty work.
जिस्मों का है ये जलवा, किस्मों का है ये जलवा, शोहरत भी नहीं ये जलवा, मकसद भी नहीं ये जलवा.
Tell 'em like it is. I can't hear.
दिलकश लगे ये जलवा, मैं कश लगे ये जलवा, नशा ही नशा ये जलवा, मजा ही मजा, नशा ही नशा.
Throw it up, throw it up.
आग सी रवानियां,
I know a lot of y'all wouldn't expect it.
लेती गए अंगड़ाइयां, ये जला दे दिलों में चिंगारियां. ये जलवा, ये जलवा, फैशन का है ये जलवा, ये जलवा, ये जलवा, फैशन का है ये जलवा, ये जलवा, ये जलवा, फैशन का है ये जलवा, ये जलवा, ये जलवा, फैशन का है ये जलवा.
She got the styling in her. Not even smiling in her. She got the styling in her.
Come, come along, feel the rhythm is in the air. Shake it on, yeah. Keep swinging in style. Move by my side as the music is soaring. Go on shouting and roaring, dancing on the high.
है अदा का नजराना, हर जुबा को अफसाना, हर किसी पे छा जाना. हो ये जलवा, हो ये जलवा, कर दे सबको मस्ताना. है जमाना दीवाना, दिन में दौरे दिखलाना. है ये जलवा, है ये जलवा, हो किसी रवानियों.
I know a lot of y'all wouldn't expect it.
लेती गई अंगड़ाइयां, ये जला दे दिलों में चिंगारियां. ये जलवा, ये जलवा, फैशन का है ये जलवा, ये जलवा, ये जलवा, फैशन का है ये जलवा, ये जलवा, ये जलवा, फैशन का है ये जलवा, ये जलवा, ये जलवा, फैशन का है ये जलवा.
Let me see your hands up. That's right. Hit me with it.
इसने सबको भरमाया है अजब इसकी माया, कोई भी बच ना पाया. हो ये जलवा, हो ये जलवा, आसमां भी दिखलाया, जमीन पे भी ले आया, गाना इसने करवाया. हो ये जलवा, हो ये जलवा, आग सी रवानियां.
I know a lot of y'all wouldn't expect it.
लेती गए
I can't hear.
दिलकश लगे ये जलवा, मैं कश लगे ये जलवा, नशा ही नशा ये जलवा, मजा ही मजा, नशा ही नशा.
Throw it up, throw it up.
आग सी रवानियां,
I know a lot of y'all wouldn't expect it.
लेती गए अंगड़ाइयां, ये जला दे दिलों में चिंगारियां. ये जलवा, ये जलवा, फैशन का है ये जलवा, ये जलवा, ये जलवा, फैशन का है ये जलवा, ये जलवा, ये जलवा, फैशन का है ये जलवा, ये जलवा, ये जलवा, फैशन का है ये जलवा.
She got the styling in her. Not even smiling in her. She got the styling in her.
Come, come along, feel the rhythm is in the air. Shake it on, yeah.
ചിന്തിക്കോ മഞ്ചണി വർണ്ണ ചുന്ദരി വാവേ തങ്കിണ്ണക്ക തകതിമിയാടും തങ്കനിലാവേ
जिया चले जा चले जिया चले जा चले नैनु तले धुआं चले
പുഞ്ചിരി തഞ്ചി കുഞ്ചിക്കോ മുന്തിരി മുത്തൊളി ചിന്തിക്കോ മഞ്ചണി വർണ്ണ ചുന്ദരി വാവേ തങ്കിണ്ണക്ക തകതിമിയാടും തങ്കനിലാവേ പുഞ്ചിരി തഞ്ചി കുഞ്ചിക്കോ മുന്തിരി മുത്തൊളി ചിന്തിക്കോ മഞ്ചണി വർണ്ണ ചുന്ദരി വാവേ തങ്കിണ്ണക്ക തകതിമിയാടും തങ്കനിലാവേ
जिया चले जा चले नैनु तले धुआं चले रात भर धुआं चले जानू ना सके जिया जले जले
আসিল ফাগুন মাসে পরাণ ঘাসে নতুন বিয়ের ফুল ফুটেছে উথালি পাথালি মনে আলতা কোণে নতুন বিয়ের ফুল ফুটেছে কিনি বিনি টাপাটিনি টানা টুনি টাসা সাহেব বাবুর বউ এসে দেখতে ভারী খাসা ধুলো কুটি গৌরী হেন ঝি তোর কপালে বুড়া বর করবো আমি কি নতুন বিয়ের ফুল নতুন ঝিঙে ফুল বাঁধলো সখী চুল বিবিয়ানা ਭਾਵੇਂ ਸਾਰੀ ਦੁਨੀਆ 'ਚ ਜਾ ਕੇ ਵੇਖ ਲਓ ਹੁਸਨ ਮੁਕਾਬਲਾ ਕਰਾ ਕੇ ਵੇਖ ਲਓ ਭਾਵੇਂ ਸਾਰੀ ਦੁਨੀਆ 'ਚ ਜਾ ਕੇ ਵੇਖ ਲਓ ਹੁਸਨ ਮੁਕਾਬਲਾ ਕਰਾ ਕੇ ਵੇਖ ਲਓ ਫਿਰ ਵੀ ਜੇ ਕਿਸੇ ਨੂੰ ਇਹ ਝੂਠ ਲੱਗਦਾ ਅਰਸ਼ਾਂ ਤੋਂ ਪਰੀਆਂ ਬੁਲਾ ਕੇ ਵੇਖ ਲਓ ਰਾਵਾ ਸੱਚ ਰੱਬ ਦੇ ਦੁਆਰਾਂ ਵਰਗਾ ਰੂਪ ਕਿਤੇ ਨਹੀਂ ਪੰਜਾਬੀ ਮੁਟਿਆਰਾਂ ਵਰਗਾ ਭਾਵੇਂ ਸਾਰੀ ਦੁਨੀਆ 'ਚ ਜਾ ਕੇ ਵੇਖ ਲਓ ਹੁਸਨ ਮੁਕਾਬਲਾ ਕਰਾ ਕੇ ਵੇਖ ਲਓ ਭਾਵੇਂ ਸਾਰੀ ਦੁਨੀਆ 'ਚ ਜਾ ਕੇ ਵੇਖ ਲਓ ਹੁਸਨ ਮੁਕਾਬਲਾ ਕਰਾ ਕੇ ਵੇਖ ਲਓ
यहाँ हर कदम कदम पे धरती बदले रंग यहाँ की बोली में रंगोली सात रंग यहाँ हर कदम कदम पे धरती बदले रंग यहाँ की बोली में रंगोली सात रंग धानी पगड़ी पहने मौसम है नीली चादर ताने अंबर है नदी सुनहरी हरा समंदर है रे सजीला देश रंगीला रंगीला देश मेरा रंगीला देश रंगीला रंगीला देश मेरा रंगीला 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 देश मेरा रंगीला देश रंगीला रंगीला देश मेरा रंगीला 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 देश मेरा रंगीला
Jalva, Jalva. Yo, blaze up the walk, light it up to the beat. Come on, Jalva. Give it to me, Jalva. Give it to me, Jalva. Gorgeous with attitude and every latitude.
कृष्णा हरे कृष्णा 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 देवकी नंदन तुमको वंदन रखते सबकी लाज सबके स्वामी अंतर्यामी पूरन कीजे काज देवकी नंदन तुमको वंदन रखते सबकी लाज सबके स्वामी अंतर्यामी पूरन कीजे काज मन मंदिर में सजे बिहारी मनमोहन तेरी छवि अति प्यारी मन मंदिर में सजे बिहारी मनमोहन तेरी छवि अति प्यारी बंसी बजैया रास रचैया तारनहार मेरे तुम ही के खेवैया, तुमसे बड़ा कहा कौन कन्हैया। श्री कृष्ण गोविंद हरे मुरारे, हे नाथ नारायण वासुदेवा। श्री कृष्ण गोविंद हरे मुरारे, हे नाथ नारायण वासुदेवा। देवकी नंदन तुमको वंदन, रखते सबकी लाज। सबके स्वामी अंतर्यामी, पूर्ण कीजिए काज। लीला परंपार तेरी तू माखन चोर कहावे। भवसागर से सबकी नैया तू ही पार लगावे। भक्तों का सहारा तू बांसुरी वाला, मथुरा के बसैया ओ नंद के लाला। तेरी भक्ति में नाचे सबका भैया। श्री कृष्ण गोविंद, श्री कृष्ण गोविंद हरे मुरारे, हे नाथ नारायण वासुदेवा। हे नाथ नारायण वासुदेवा। देवकी नंदन तुमको वंदन, रखते सबकी लाज। सबके स्वामी अंतर्यामी, पूर्ण कीजिए काज। देवकी नंदन तुमको वंदन, रखते सबकी लाज। सबके स्वामी अंतर्यामी, पूर्ण कीजिए काज।
Jalva, Jalva, yo, blaze up the walk, light it up to the beat. Come on, Jalva, give it to me, Jalva, give it to me, Jalva. Gorgeous with attitude and every latitude. Miss hot booty, come on, baby, do your duty work.
जिस्मों का है ये जलवा, किस्मों का है ये जलवा। शोहरत भी नहीं ये जलवा, मकसद भी नहीं ये जलवा।
Tell him like it is, I can't hear.
दिलकश लगे ये जलवा।
लहंगा देखो घूमर यार मेरा, जीरा देखो झूमर यार
करे से सल्यूट मन्ने गाँव में उसका, मन्ने चौधरी साहब धरा नाम उसका, हो से जो सरकारियों का काम रिसकी, हो मेरो बालम थानेदार चलावे जिपसी, हाय मेरो बालम थानेदार चलावे जिपसी, हाय मेरो बालम थानेदार चलावे जिपसी। सारे शहर में चले से यो रोब बेरी का, मेरे आगे गुस्सा ठंडा पड़ जावे से जहरी का, ओ सारे शहर में चले से यो रोब बेरी का, मेरे आगे गुस्सा ठंडा पड़ जावे से जहरी का, हे सर्दी में पीवे रम, हे गर्मी में विस्की, हो मेरो बालम थानेदार चलावे जिपसी, हाय मेरो बालम थानेदार चलावे जिपसी, हाय मेरो बालम थानेदार चलावे जिपसी।
Jalva, Jalva, yo, blaze up the walk, light it up to the beat. Come on, Jalva, give it to me, Jalva.
Jalwa, Jalwa. Yo, blaze up the walk, light it up to the beat. Come on, Jalwa. Give it to me, Jalwa. Give it to me, Jalwa. Gorgeous without.
पधारो साधु मरदी खेल पान अलम धरो गुरल गुरल गुरदाल आस मारो जीवड़ो घड़ो हिचकावे ओ घबरावे मन में भावे मारो पागलो भवन मन भावे चमक चम बाजे बायल बाजे बाई सकेरे चमक चमक भुगत बाजे आओ साधु मरदी खेल पान आओ साधु मरदी खेल पान
गवाची हवे तो लौंग वे मैं लाची तेरे पीछे आ गवाची तेरे इश्क ने मारी कुड़ी कच दी कवारी तेरे इश्क ने मारी कुड़ी कच दी कवारी वे मैं चंबे दे पहाड़ा वाली शाम वे मुंडिया संदली संदली नैना बिच तेरा नाम वे मुंडिया संदली संदली नैना बिच तेरा नाम वे मुंडिया संदली संदली नैना बिच तेरा नाम वे मुंडिया हाँ मेरे सुन
Laughter for happier, healthier, and graceful living. I am Dr. Santosh Sahi, a laughter yoga teacher and leader. Let's celebrate life with laughter. Come on, sing and dance with me.
Life is laughter, life is laughter, ha 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 ha. Be happy, ha 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 ha. Life is fun, ha 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 ha. Be happy, ha 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 ha. Life is dance, let us dance, ha 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 ha. Be happy, ha 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 ha. Life is love, ha 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 ha. Be happy, ha 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 ha. De-stress, ha 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 ha. Be happy, ha 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 ha. No fear, ha 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 ha. Be happy, ha 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 ha.
Thank you, ma'am.
Jalwa, Jalwa. Yo, blaze up the walk, light it up to the beat. Come on, Jalwa. Give it to me, Jalwa. Give it to me, Jalwa. Gorgeous with attitude and every latitude. Miss hot booty, come on, baby, do your duty work.
जिस्मों का है ये जलवा, किस्मों का है ये जलवा, शोहरत भी दे ये जलवा, मकसद भी दे ये जलवा.
Tell them like it is. I can't hear.
दिलकश लगे ये जलवा, मैं कश लगे ये जलवा, नशा ही नशा ये जलवा, मजा ही मजा, नशा ही नशा.
Throw it up, throw it up.
आग सी रवानियां, लेती गए अंगड़ाइयां, ये जला दे दिलों में चिंगारियां. ये जलवा, फैशन का है ये जलवा, ये जलवा, फैशन का है ये जलवा, ये जलवा, फैशन का है ये जलवा, ये जलवा, फैशन का है ये जलवा.
She got the styling in her. Not even smiling in her. She got the styling in her.
Come, come,